That's a charger. It's fine.
I muted myself. We have some interesting presentations today, statistics that that I think are illuminating, and we have some legislative updates for you, one of which I'm very excited about. So that's a little teaser for later on. We're up to 34 people. Let's give it another minute.
All of the add-ons that I sent, the 3 presentations, anybody would.
I'm informed that some of the .gov emails kicked out our materials. So you may not have gotten them. So this will be like a new thing. And also, as happens, we sometimes update. And so this morning, you probably have received some updated statistical information. Again, we'll go through most of it, all of this during the meeting. And then online, we'll have all the final materials, as well as the recording of the meeting, as we always do. So one thing you can always do is look back, and any meeting you'd like to hear a part of, you can go into the state attorney website for the 15th Judicial Circuit and be able to listen to parts of the meeting or view the materials. With that, we're over 40 people, so let's get started. I'm going to ask some of the members of the newly minted State Attorney Addiction Recovery Task Force, formerly Sober Homes Task Force. First, Dr. Alina Alonso. I know she's really busy these days, but Dr. Alonso, are you or any of your representatives on? And whoever is not muted, please. Okay. I saw Dr. Andriek, Dr. Belma Andriek, you with us from the Healthcare District of Palm Beach County?
Hi, good afternoon. And I have a new team member that I want to introduce, Joven Arnhem. I saw him somewhere, John. Yes. So John, some of you know John. He's our behavioral health consultant right now. And we have Richard Ellis on this call. And I saw Darcy as well. So that's all healthcare district team here.
Well, I certainly know John, former assistant county administrator, and welcome to your new role. You do have a lot of knowledge that you bring into the healthcare district, so welcome, sir.
Thank you.
Now, can I get the more volume, please? I'm not hearing. Dr. Jennifer Atenito from FAU, College of Business Health Administration.
Yes.
Yeah, there you are. Right.
Good afternoon.
Good afternoon. Tom Baird, attorney, Jones and Foster. He's also a municipal attorney for a number of different municipalities. Tom, you with us?
Yes, good afternoon,
Hey,
everyone.
Tom, there you are. Okay, Turner Benoit, Hanley Foundation. There you go. Hi,
Hi.
Turner.
Hi, Al. Hi, everyone.
Nice to see so many people that are actually, I can see you. You know, a lot of times you're on a Zoom call, or especially a mass one like this, where there's, you know, there may be 60, 80 or 100 participants. It's like, you know, looking at names, but okay. Ariana Ciancio, Delray Beach Police Department advocate. There you are, Ariana.
Hi.
Darcy Davis with the Healthcare District. Darcy, you with us as well?
I am here.
Hi. Steve Farnsworth from Florida Association of Recovery Residences, FAR. Steve?
I'm here. Thank you. I'm here.
Great. Suzette Fleischman, DCF, Department of Children and Families. Suzette, you with us today? I think she'll be signing on in a little bit. I know she's really busy. Well, we all are. I don't think Mark Fontaine's here, but Uta, you with us?
Good afternoon, I am, and you will not be seeing my flu face. It's pretty gross, so, but I'll be here.
I know. Well, I hope you feel better soon. I didn't realize that you were under the weather. Well, feel better soon. Anyway, Uta has replaced Mark Fontaine, which is for formerly what was FATA, Florida Alcohol Association of Addiction Treatment. No, what was FATA? See, that's why you changed your name to now you're
Florida Alcohol Drug Abuse Association.
that's what it used to be. Now you're Florida Behavioral Health Association, which is so much easier.
Correct.
Okay, and Lori Holzclaw Hunt, you with us from Oxford House, Lori?
I am here, Al.
Hi. Okay, John Hewlick, Palm Beach County Community Services Department, the drug czar.
Hello there, Al.
Hi,
Mhm.
John. Stephanie Tu, my friend from the Office of the Attorney General. Stephanie, you with us?
I am. Hello.
Hi. Long time no see. Maybe when the pandemic wanes, we'll actually see you at some conferences live.
Yes, looking forward to it. Thank you.
Okay. Jeff Lynn, private attorney, expert in the the department rules and also zoning. You with us, Jeff? I saw you.
Yeah, I'm here, Al. Good afternoon.
Hi.
Hi.
Neil McGarry, FCB, Florida Certification Board. Neil, you with us? Okay. Melissa McKinley, I think Joseph, are you with us?
Yes, good afternoon, Al. I am here
Okay.
representing Commissioner McKinley.
Okay, great. Dr. Moran, I saw you on, Dr. Robert Moran, Medical Director, Family Center for Recovery. He's a psychiatrist.
Right here, Al.
And Dr. Rachel Needle, our licensed psychologist.
Hi.
Hey, how's it going, Rachel?
Good, thanks.
Terrell Pyburn, Coconut Creek City Attorney. Terrell, you with
Hello.
us?
Yes, I'm here. Happy New Year, everyone.
Happy New Year. Susan Ramsey, also an attorney, and I don't know the law firm because you left Romano, but I haven't kept that.
McLaughlin and Stern now. Hello,
Okay.
everyone. Yes, I'm in the towers of McLaughlin and Stern. Happy New Year, everyone. Thanks, Al.
You bet. Terry Shapiro, Hanley, Center at Oranges. Terry, you with us? Okay. Nikki Soda had a death in the family, unfortunately, so she won't be presenting today. And I'm sure she's not on from NAATP, National Association of Addiction Treatment Providers. We'll get her advocacy toolkit, how to advocate in state and federal government presentation in March at our next meeting. Alton Taylor, you with us? Alton? Okay, Ann Berner from the managing entity, Saartf, Southeast Behavioral Health Network. Are you with us, Ann? Okay, Dr. Vinacore, Lori, are you with us? Oh, that's a first. I don't know that Lori's missed a meeting in the last 2 years.
She's gonna be here about 1:15.
Hmm?
She's gonna be here about 1:15.
Oh, 1:15, see? Okay.
She's gonna be a little late.
And Eric Urlano, Eric, I thought I see, oh, there you are. Hey, you're in the flesh this time, not sending one of your associates. Good to see you, sir. Happy New Year. Well, Happy New Year, everybody. I believe, I don't know if we do have the new director of the Florida Office of Drug Control, Doug Simon, newly appointed. He told us that he was going to stop by and join the meeting. I don't know if he's on yet, but hopefully he will be on before long. Okay, I will remind everybody who's monitoring this, auditing this, the public is always invited, and we have plenty of you that show up, which is a great thing. That there'll be a public comment section at the end of the meeting where if you have any questions or you want to make any comments, you'll be given an opportunity. So I'm going to go into some pretty grim statistics, actually, really grim, but very telling statistics on opioid overdoses. Let's get up the first page, please. Which one are we starting with?
You want this one?
Yes, let's start with that one. This, as you all know, the FDLE Annual Medical Examiner's Report came out in late November and then promptly disappeared from the Zoom meeting. But I do want to go over, while we're getting that back up, we had a state attorney analyst go through the numbers because unfortunately the state numbers are flawed. And there's a reason for that, is that sometimes the medical examiner will not call one cause of death. You may get 2 causes or even 3 causes. It could be fentanyl, cocaine, alcohol. There could be several. So we don't have in the report itself an accurate count of 1 death, 1 drug. What we did was we got the raw data and went through the entire state, all the state numbers. And when there was a multiple cause of death and one of them was opioid, we called it as opioid. And that these numbers are more accurate as far as 1 death, 1 drug. It's been a horrible year for Florida in 2020. Now, obviously, we're done with 21. We won't see the 21 numbers till next November. But hopefully they'll go down some. But 6,089 opioid caused deaths, average of 16.7 deaths per day in the state of Florida, which is a 30% increase over 2019 when we had 4,294. I mean, I don't know how much worse it could get. Of course, it could always be worse, but a 30% increase in 1 year is awful. Now, one of the telling statistics that we were able to glean was fentanyl or fentanyl analogs caused death or was present in 5,818 cases. Very few fentanyl analog causes. 5,818 cases, which represents 95.5% of the opioid overdose deaths were caused by fentanyl or fentanyl analogs in the state of Florida. We have a fentanyl crisis. We have some things, there's some legislation we'll be talking about a little later on that I think is going to save hundreds, if not thousands of lives. And it's something we should have done last year, but didn't think of it, frankly. Pasco, so I want to go through the 5 leaders, the worst of the state of Florida. Okay, Pasco, Pinellas counties led the state with 688 opioid caused deaths, not just presence, caused deaths. It's 29% increase. They had 492 last year. they vaulted into first place. Broward County passed Palm Beach County by recording 662 opioid-caused deaths. That's a 36% increase from last year, from 19, not last year, but these are 20 numbers from 19, which was at 426. Palm Beach County recorded 604 opioid-caused deaths. We had 476 in 2019. That's a 26% increase. Clay, Duval, Nassau counties recorded 581, a 27% increase over the 425 in 2019. And Hillsborough County recorded 409, which was a 47% increase from 217. The entire state pretty much went up. I mean, when you look at that 30%, all these 5 counties are in line with that, anywhere except for Hillsborough. But the rest is, 27 to 36%. So you can see how all over the state the numbers went up last year. Next slide, please. Now, 2021, we've got preliminary numbers from our medical examiner and also from Delray Beach. With regard to the medical examiner's information, it is a snapshot. And you can tell by the numbers as of January 1st in 2020, we went far above that to 604. So there are many cases that still need to be analyzed, the toxicology reports, but still, as of this January 1st, we're 14% below the 2020 numbers, 444 as opposed to 514. Now, that could change. We don't know how many cases are in the queue. We'll have a good idea within a few by May. So in March, we'll give you, additional numbers, and then in May, we'll give you probably what will be the final numbers. Delray Beach is really interesting because that was, and one of the reasons we followed Delray is because that is the epicenter, or was the epicenter of the opioid crisis in the state of Florida back in 2015 and 16, and the epicenter of the fraud. Ariana, what's the population of Delray Beach, give or take? Is it 69,000?
Sounds good.
Yeah, I think it's around 69, it's under 70,000. 2019, there were 44. You see the spike in 2020 up to 63. Thank God we're 33% below the 2020 numbers at 42. It's still, as you can see, for 69,000 people, that's a lot of overdose deaths. So, we'll be keeping tabs on that. But thanks to some innovative things that are happening, the hub opening up in South County, the work of Ariana and the Delray Beach Police Department, I think those numbers will go down. But we're no longer in a situation where people are in the Florida shuffle and they're dying because they're recycled in and out of treatment and they eventually overdose. Now, it's many people who have turned out of their parents' insurance policies. But the fentanyl that is on the street right now, infecting all drugs, marijuana, cocaine. There was a piece in the Palm Beach Post about a chef that got some cocaine after one of his shifts, and it was laced with fentanyl, and he died of an overdose. We're hearing about Adderall at universities that's spiked with fentanyl. This is incredibly devastating, and again, I'm gonna wait to give you the statutory change that we think will save many of these lives that are getting bad drugs off the street. Next slide, please.
That's it. That's all you got.
You don't have the fire rescue slide?
I do.
Okay, very good. That's the third one.
I know.
Okay, fire rescue numbers are fairly stable in Palm Beach County. And I just want to let you know that the net change from 2017 to 2021 has been a 36 to 37% reduction in the transports for opioid suspected overdoses. You can look at the numbers yourself. We're a little below, 4% below. We had a bad year in 2020, pandemic related, I'm sure, fentanyl related as well, but we're moving in the right direction. We have a slight decrease from 2020. Our biggest decrease was 2018 when the Sober Homes Task Force came into being and Narcan became more readily available. I think what our problem is now that we didn't have in 2017 and 18 is the fentanyl. Even last year meaning 2019 in the state, it was 84% as opposed to now 95.5%. Okay, let's move on. Any questions on the statistics? Any comments from the task force? Seeing no hands. Okay, let's move on. We're now at FAR, and let's get some current the current data from Steve Farnsworth.
You want me to share my screen like I did before?
Yeah, you're going to share your screen. That's fine. Thank you. It keeps our hair from getting grayer when you all share your screen.
Okay. Okay. So it's a typical same report that I give every month. It's really not a whole lot of formatting changes except for one area and the overdoses that I'll get to in a second. But these are my January 10th numbers. I have 103 programs certified across the state. A program might have more than one location, and so when you see the units, that's locations that we have certified, and then the number of beds. The level 4 beds are components of treatment centers, so you have to be in their treatment in order to be in one of those beds. So we need to consider that when you're thinking about the capacity. But last year around this time we had 6,740 fluctuating through the year, and now we're at 6,870. So we're about 130 more than we had last year. We've lost some, we've gained some. That's the number of beds, but only 4,659 of them are actually available for people who are not in the treatment program. And then you see the numbers for the units, and we got it broken down by men, women. Both is not co-ed. We still don't really. I mean, we will vet a co-ed program, but as of yet, we have no co-ed program certified. But so both means that it's a program that has men's houses and then women's houses. So for the counties, Broward, Broward has 32% of the beds. Palm Beach has 39% of the beds. And so we're looking at, just under 75%. Is that right? 70, 60, yeah, 71% of all the beds in the state of Florida are between these two counties. And then you can see the breakdown in the other counties, and the rest of the state makes up that other 29%. Overdose numbers. So these are 1 year totals. These are the numbers back to January 1st. We have a self-reporting requirement for the FAR certified houses. I feel confident that people are complying, because when there are overdoses, it's kind of difficult to keep that hidden. And so people are reporting. This is only overdoses within FAR certified recovery residences. And so for the last year, I have 58 total. And then you can see the male, female, and how many were deaths. 33% resulted in a death. This new section right here that I just put in this time for the first time, what I noticed is that the number of overdoses were the same in December of 2020, but I had 69% deaths back then. And then in January, I had 64%. March, I had 57%. And then you can just see how it, for whatever reason, it's coming down to now. Today I have 33%, and your guess is as good as mine as to the cause of that decline. We'll take it, of course. My guess is that it's the availability of Narcan, as well as a lot of awareness and training and quick action with people. But we can discuss that when I finish my report. You got your breakdowns for the cities. Fort Lauderdale and Pompano still get something going on down there. And then my age reports, average age 33. I don't think that's a surprise. I don't think the drug preference is a surprise. There's 52 people reporting that were opiates. The overdosed person was using opiates. I was requested to start asking for how many doses of naloxone was actually administered. The one person said they did 1, 6 people said 2, 1 person said 3, two people said 4. So 2 seems to be the typical number. The certification level, level 1s are the we don't really have very many in Florida. We do have a couple. Typically, they are attached to as a step down program from a higher level certified program. But the majority of the overdoses are obviously in level 2, where I have the least amount of supervision. Although I did have 3 in level 4 treatment center housing components. If they came to Florida for the purposes of recovery, I asked them to tell me what state they came from and how long they've been in Florida. And so those numbers are right there. We had this one person that overdosed and died within 24 hours of arriving in Florida. And then you can see how the numbers go from there all the way up to 15 years. The rest of the stuff that I put on this report is for your reading enjoyment, as far as what FAR is about, what NAR is about, the steps to get certified, and our Partners in Excellence program if you want to support FAR. So that's pretty much all I have for the report. Do we want to take questions, Al?
Yeah, before we go to questions and comments, I just, every time you give your update, I become more and more astonished, even though it fluctuates a few more, few less, as to how many beds that FAR certifies in the state of Florida. I think you told me that the nearest NAR affiliate I think it's in 40 states right now, NAR?
32, I think, with some that are kind of in the vetting process right now.
Right. There's nobody that's even 1,000 beds in the state.
Yeah, whenever there's a report nationally and Florida comes up, the response is, yeah, well, that's Florida. They're different.
Well, and I think that's in a good way.
Oh yeah,
I think others should emulate this because, as we always discuss, housing is critical to recovery. If we want to get a handle on this epidemic, whether it's opioid or fentanyl, a good, safe housing is a key, is an absolute key to long-term recovery. So kudos to you. I think and I'm just spitballing right now, just throw it out there, that one of our main legislative priorities for the 23 legislative session should be an appropriation to FAR, because the state is not giving you bupkis. That's a technical term right now. And you're doing it all on your own with the fees that you're charging, which is kind of counterproductive if you charge too much in the way of fees. But also, and I'll be talking about this in a second, but Suzette Fleischman sent us the last data that we got from DCF, and it continues to remain the trend. We've lost 33% in South Florida, 33% of our component licenses, and they've migrated north to those places like Pinellas, Pasco, Orange County, Jacksonville, Duval, places where there are a dearth of certified houses or certified beds. 81% in what, 3 counties or 4 counties? On the rest of Florida has 19% of the FAR beds but they have a larger number of the component licenses that would require housing ordinarily, like IOP and day night. But anyway, any questions or comments on the FAR numbers or the FAR update from anybody?
Hang on, wait, I'm gonna mute somebody. Hold on.
Anybody?
I'd also like to talk about respite before you move on away from me.
Well, we got respite coming down later on. Hopefully we'll get to it. I think we will, since we've lost one of our presenters today. So, okay. Now the Addiction Stabilization Unit, the ASU, we have an update. We now have year statistics, which is one great thing. So we have a little bit to bite onto. But the other thing is every time we do have an ASU update, I just want to remind everybody who may not be familiar, who may be tuning in here for the first time, that we have a program in Palm Beach County that is, I believe, being emulated in other parts of the state and the country, which is a trauma model with the emergency room having professionals, having a psychiatrist on, addiction psychiatrist on staff, having the proper folks in the emergency room when people come in on an overdose. And then we have an attached, not physically, but Palm Beach County Healthcare District has an addiction stabilization unit, which is geared toward people coming in, whether they walk in or come in from the emergency room as a referral, so that they can get a warm handoff. They can start their path to recovery and not just run out of the hospital AMA, because they've just been recovered by Narcan from an overdose, and now they're in withdrawal. So with that little intro, who is Belma? Who is going to be presenting?
Yes, I will present today. Courtney is in a clinic. I'm just trying to. Do you guys see my screen?
Not yet.
Okay. Let me just. Do you see now?
Yep.
Got it.
Yes.
Okay. Oh, sorry. Just I'll keep it like this way. Good afternoon, everyone. Either me or Courtney on monthly basis gives you updates on some statistics and some new initiatives that we have in our program. So these first slides, do you guys see my screen? Okay, I see some nodding. It represents like data started July 1st last year until January 23rd, just a few days ago. The reason why it's from July 1st is because that's the time that we switched to our new electronic health records, and that's kind of the simplicity of data presentation. And we increased many data fields that we collect since that time. So we have some other data that talks before that, but for the purpose of those presentations, we are focusing since July last year. And you can see on the top total number of patients, unique patients, as well as total number of patient visits. Some patients come multiple times here. You can see a little bit of demographics. 70% of the patients coming to SU are males. Age range continues to be the 31 to 40 is predominant decade, as well as white, race, and non-Hispanic ethnicity. On the left upper corner, you can see monthly trends. We have drop in month of November and December. January is kind of really recovering a little bit last few days. But around the holidays, we have a traditional drop in the patient seeking help. And that's something that I think knowing that addiction is illness of isolation, something that we all should focus and we do in the clinics. We actually discussing that on a regular basis, what can be root cause of that. But anyway, the middle left section of this slide talks about mode of transportation, continue to be walking as predominant one, followed by the Palm Beach County Fire Rescue Transportation and City of West Palm Beach Municipality, the transfer as the second and third most often here. Length of stay, same day discharge. Actually, 1 day is the highest number of days. Usually this kind of stay, 1 day is if we have two different dates in our system, that means they stay overnight or came late and stay until morning. We similarly to Steve collect data on what percentage of patients said that they're born in Florida and how many of them kind of came to the Florida for treatment. 15% of the patients report that they came here for the treatment. You can see like, a little bit month-to-month data statistics on the bottom. This is like how it looks when we look into their urines. Urine drug screens that are performed in the emergency room. Cocaine continue to be the most predominant urine drug screen, followed by the fentanyl, followed by the marijuana. We don't even have a heroin anymore. Like Dr. Phillips often say, we didn't see heroin in the urine for years now. Again, fentanyl This is one of very few emergency rooms in the county that has a fentanyl urine dipsticks. And we continue to push for all other emergency rooms to do that, because you miss a lot if you don't test for fentanyl. Again, heroin is a part of regular drug screen, but it's not showing up because it's completely replaced by fentanyl in our urine drug screens. This is, again, emergency room drug screens. You can see on the left side is when you group those drugs, right? So polysubstance is the lead, followed by polysubstance plus ethanol, alcohol. Then the third admission for the into JFK addiction stabilization unit is alcohol only. And you can see a little bit data on alcohol. You can see a little bit of data, how many of those that are qualified. That means that they have opioid in their system and they're diagnosed by moderate to severe substance use disorder with opioids. They are qualified for Suboxone induction, and 64% of them that do get induced while they're in emergency room. So that's kind of middle right section of this slide. On the bottom, you can see the drug screening combinations. It's absolutely endless number of combinations, but just another kind of polysubstance proof that there's really using multiple drugs. This slide talks a little bit more about overdose history. You can see how many of them report overdose in the past. 48% report history of overdoses. 8% of patients are overdose reason for visit on that visit. So that mainly of them are transported by the fire rescue versus walk-ins are just coming because of withdrawal symptoms or just know about addiction stabilization unit as potential access to care and continue to come back for that same reason. Number of overdoses is self-reported by the patients. And you can see the range of those numbers. Also reported by patients history of treatments. I continue to be impressed that 30% of the patients report no history of previous treatment. What in another is another proof that this program is important access to care. Then reported for the patients, how many of them carry Narcanes, 12%. That number went up during the time. Patient participate clean needle exchange program. I think this number also as well is going up, as well as Baker Act history. You can see on the bottom of what happens to the patients after assessment in addiction stabilization unit. We have for the first time a little bit more first category talks. AMA stands for against medical advice. So when people just leave. We have like 10 patients in December. We just had a meeting with JFK team looking a little bit more why we had that jump from average one to few to 10 in month of December, and they're looking into that. Then what percentage of patients went home versus what percent of the patient choose a healthcare district outpatient clinic as the next step, as well as how many patients are referred to other treatment facilities. This third category, healthcare district, obviously is most important for my organization. What percent of the patient choose the clinic as the option for their warm handoff from the ASU? And as you know, we have embedded recovery coaches, whether trained peers in this unit almost every day. Actually, we do have it every day, including weekends until late afternoon hours. So that warm handoff is another important aspect of this program. That being said, you can see that like around 50% of the patients who come to ASU do go to the healthcare district clinic traditionally. And then of those patients who are warm handoff to the clinic, 80%, 79% of them have 2 or more visits with the healthcare district clinic. What is another very important indicator for us that they keep coming. We know that this is chronic relapsing illness, especially early in the recovery. We want to see multiple visits. So that kind of can be indication of some compliance to recommended treatments. This slide talks a little bit more about what we find, what their needs are. Housing and food continue to be the lead ones. This is what we address once then. This is what licensed social workers in the ASU start addressing right away, but we continue addressing in a clinic and try to connect to any other community resources. We try not to leave patients behind. We try to find any voucher beds or food solutions. We help them apply for food stamps, etc. The other part of this slide are kind of internal use to see how they heard about it and what's the reason for ER visits. This is the first time that I'm presenting a little bit more dive into the clinic. Once we have, some of you know that we have 2 outpatient clinic in like 2 years ago, we had only 1. Now we kind of consider Lewis Clinic as our second addition clinic where we move our patients that are in higher phases of treatment. So we have 2 full-blown addiction clinic outpatient based. And this is like first time I'm presenting data, and pay attention in the right upper corner. This is data from October 1st until a few days ago. So this is, again, many of those patients from ASU come in a clinic and stay in a clinic, but many of the patients are identified through our primary care clinic, and many of the patients are referred to the outpatient clinic from other resources without ASU. So it's overlapping significant amount of patients. As I told you, 80% of the patients from ASU stayed in the clinic, but keep in mind some of the patients never went through ASU, what I'm presenting here. Age and demographics are pretty similar. Phases of treatment, that's another thing that we track, right? How many of them are what phase? But 43% of those patients are homeless compared to 17% of our total population as the federally qualified health centers. So this population has significantly higher number of homelessness. Keep in mind also as a federally qualified health centers, once somebody is marked as a homeless in our system, they stay homeless for a year in our system because we think they're very vulnerable. And although they find a housing, we still carry them as a homeless because we want to address that at each visit. Visit types, this is something that we really work hard on collecting data and to kind of see who are the patients that leave the program. Good news is that we have a lot of new intakes. We also have a lot of return visit. What is the main goal of our program? To be available for them, to develop relationship with the patient as their medical home for their substance use disorder. So they know where to go back, and many of them do come back because this is relapsing illness. And how many of them are readmitted versus how many of them have been uncontrolled discharged. So 21% of the people will lose, right? And when we do the little bit more deep dive in, we wanted to know why we lose the patients. So we have, most of them are lost to follow up. They just disappeared off our radar. Some of them discontinued treatment. They told us they're going to discontinue treatment. That's what puts in this category. 1% expired, 1% incarcerated, and 1% for administrative reasons. But like, keep in mind, this is a subsection of that uncontrolled discharge, which is 21%. What we want to look kind of as trend during the time and see if we are improving. It is still a significant number of the patients. We don't want to see any of them in this category, but it's not in the big picture. It's the smallest subsection. Percent of the patients with at least 1 overdose in the past 3 months. I was excited when Steve presented some of his data. We track the same way. We just, those 0, 3, 6, 9, 12, 15, those are months interval when we collect this data. So you can see when they, during the time we want to see these numbers to go down, and that's what you see in this graph as well. This is something that we are closely monitoring. And then that brings us to the brief addiction monitoring tool. I talk about this a few times. I know, what's his name? John Hulick is on this call. He's gonna probably talk about very similar, like sister tool that he's trying to implement countywide. I forget the name, John. Please apologize for that. But I for the first time, I actually brought here what we ask in this tool. Again, this is when we implemented program, we are looking for evidence-based tool, how we monitor long-term outcomes of our programs. And this was recommended by some academical institutions that we reach out to as the best tool to monitor in that time. John is using equivalently evidence-based tool. Again, this is evidence-based tool recommended but obviously they're similar. Maybe they're different in some questions and we can compare them, but I'm pretty sure they're overlapping in a few. And when you see what the questions are, they group them in 3 different categories. Again, this is like 17 questionnaire that are administered to our patients, either by they either self-determine that, or the therapist asks them those 17 questions. In each of those questions in this tool is categorized as one in those 3 categories, either telling you what is the average use score that addressed any alcohol use, are they taking any alcohol, are they using heavy alcohol, any drug use, and then they kind of calculate the scores to put them in this category. Obviously, this use score in the program we want to come down, right? So those like points that you see 2, 2, 1, those are the calculated risk scores. And we want for that to come down. And that's a good news that we have downward trends. The second group is average risk scores that address like self-declared physical health, sleep, mood, cravings, family relationships, risky situations that they still find themselves in. And again, those are calculated scores based on those questions. And those average risk scores also we want to see to go down. Average protective scores such as confidence, self-help, religion, did they work, right? We again calculate those we want to go up. And all those 3 groups in like those 1,600 patients, we have around 3,000 surveys, but 1,600 patients reported those scores. And you know, this is good that we see trends that we want to go down, and trends that we go up. This is a detail of the questions. This is what whole questionnaire looks like, what we ask them, and you know, then based on those categories and mathematical calculations, that's why it's important that we kind of use that tool as the
normal
right
suicide rate, I think, of children is 84 in the state of Florida.
Well, that's good in interruption because I'm done. I just put like actual questions here in case that John wants to compare those, like I believe you call John that as the recovery potential, no, recovery capital, like recovery capital tools that you use in some of the programs or trying to use. That concludes my presentation.
Okay, I want to welcome Representative Mike Caruso, who's one of our heroes in the Florida legislature, who is sponsored HB 479. The counterpart is SB 704. Before I ask how the progress is going, Representative Caruso, I do want to bring in Ariana Ciancio and John Hulick to talk a little bit about the hub and how that interacts and helps with the ASU, if it does, and also what's happening in the southern part of the county. Are we getting closer to enticing JFK Central to get on board? And because we are still having transport problems as far as the bulk of opioid overdose patients are going to JFK North, which we'll talk about when Dr. Atenito gives her presentation. So Ariana, what's going on in Delray?
Well, I definitely can't speak on the hub. That's John's thing.
Yeah.
But as far as ASU transports, I was graciously given a recovery coach from the healthcare district. So thank you very much, to come to our outreach twice a week. So we have Josh, who is the recovery coach that will sign people up for healthcare district and the ASU, whichever direction they need to go. He has been fantastic and amazing. We have transported several individuals up to the clinic. Thanks to this meeting, I was able to get the transportation bus passes to get people back and forth. So over the last 3 weeks, we've seen a great success with the collaboration between our outreach in Delray with the ASU Healthcare District and the bus passes.
Awesome.
As the hub, the only thing I could say is that our relationship with the hub is great. If they need something, they come to us, and if I need something, we go to them. But I know that John can speak 100% on the hub.
Okay, and John, an RCO like the hub, how does the county see the interaction between the hub and the ASU. And perhaps if you can comment on any progress with getting a trauma model at JFK Central. John.
Thanks, Al.
There you go.
Appreciate it. Yeah, so we're very pleased with the progress of the hub. As you know, Al, in our conversations and for others, you know, our aim is to, one of our major aims is to improve long-term recovery outcomes. You know, so historically, as we well know, treatment in essence and an outcome, a historical measure has been successful treatment discharge, which may or may hover at about 50 or 60% success rate. The county doesn't even use that in its contracts anymore as a measure. What we're measuring in our provider outcomes are improved, and thank you, Belma, for mentioning recovery capital indexing. So we're definitely aiming at improved recovery capital scores. It's a resiliency factor. You can call it risk or protective, and you know, some of these are very synonymous to the BAM, as Belma's already suggested. So you know, we're looking at that for sure. Also, you know, with respect to the ASU and long-term recovery outcome, one of the key predictors to long-term recovery outcome is length of engagement. Now, treatment providers will tell you it's length of stay. It's not. It's length of engagement. So we look at the hub at, you know, and recovery community organizations and centers at very much meeting people where they're at. They're likely in treatment, may not be in treatment, but we do expect our providers, and they are getting measured on successful handoffs to recovery community centers. And they're obviously non-clinical services in nature. You know, they're always a question, well, what services, you know, are being provided, and how should those services be informed? And my response back is always, the person walking through the door is the one that will inform you in terms of the services that should be developed. So we're excited. You know, we're excited to be able to look at expanding availability of these recovery community organizations and centers throughout Palm Beach County. It's a little bit premature in announcing anything, but we definitely have some things in the works with respect to those. So I think, Al, I've answered your question. If not, though,
Yeah, I would presume that it's axiomatic that the hub or any RCO that pops up in or has begun in Palm Beach County is going to be joined at the hip with the addiction stabilization unit for those who are in need. And I know it's a stabilization unit. You know, it's not a point of treatment necessarily, but I, you know, can I assume that the lines of communication and the interaction between the RCO and the addiction stabilization unit is vibrant, active?
Yeah, I would certainly expect that and anticipate that. As you know, we opened our doors finally in, you know, in terms of bricks and mortar, I guess in April or May of last year. So, you know, but that networking continues to happen. And again, contractually, at least with respect to our providers, we are measuring, and one of our outcomes is successful handoff,
Right.
you know, from provider to an RCO or a center.
Thanks, John. Excellent. I want to bring Joseph Sophie in on this and ask you as well about any prospects, and you know, if it's secret sauce, that's fine. Just, you know, say, hey, we're working on it. You know, the opioid dollars that may come into the budget through the federal government or through the opioid settlements. Is there any movement toward opening up? And I know last meeting, Belma, Dr. Andrick, you were talking about the fact that you're getting resources close to or nearby JFK Central. But when we look at the numbers from FAU, it's amazing how many opioid overdoses are going to JFK Central as opposed to JFK North. If we can't crunch the numbers to get them diverted to North, what's the progress and what's the potential for us getting JFK Central to be a south to mid-county stop, so that we can get more people in a situation where we have a trauma like ER and a facility nearby, a stabilization facility nearby.
Al,
Sorry.
Hi, Joseph.
I just want to
thanks.
say, like, answer to Al question, right? Because, you know, we are working with JFK in constant attempts to have that south covered, especially in the light that we are planning an expansion, not only in Delray, that is going to happen in the next 3 to 4 months, because we are opening like similar addiction clinic that we have in North, we are opening on the south. But COVID really derailed all our plans. Like, hospitals and emergency rooms are so overwhelmed by COVID. Now, hopefully, when this is subsiding, that we're going to go back to the drawing table to really, like, you know, see what kind of hybrid we can implement again. I just wanted to get that update, Al, because you asked about South.
Yeah, thanks. And we'll just keep that ongoing, and I get it. You had said that in the past, and Joseph, we've taken you off the hook because, yeah, this is on the pot, ready to turn on the burner. So let's readdress this in the March and the May meetings. And Representative Crusoe, did you want to chime in on this at all? I see you up there. Yeah.
Official Association of Florida.
Good afternoon, Al. How are you?
Fine, thanks.
Unfortunately, I just got out of committee and I just sat down in front of the screen. So I didn't hear what was going on. My staff's still talking to me behind there, trying to update me of everything going on. So
okay,
let me dial in, and maybe I'll chime in at the end.
Yeah, I just wanted to include you if you had something. But cool, hang in there because we're going to talk about 2 bills that are pending. Yours being one of them. Okay, great. Anybody, any comments? Now, we did have a question from the chat room. Belma, I thought I saw a statistic of residency. In other words, are you identifying out-of-state residents as opposed to residents and length of residency in your stats?
Yes, we have out of state versus in state, but we don't have like which states they're coming from. We don't ask questions on which state. We just ask Florida or not Florida.
Okay, it might, yeah, if it's not a big deal, that would be a statistic that might be helpful down the road in one way or another, just to gauge who's in Palm Beach County, whether they're residents, permanent residents or transplants that just came down for treatment.
Yeah, we have that statistics. 15% of them says they come here for treatment, but we didn't break down per the state. Again, this is in emergency room statistics. So those are 3 agencies that needs to kind of collect this data. So I will definitely take note of that and see if we can have drop down lists per state.
Okay. All right. Thank you. Any other comments or questions?
I just have a comment that we just applied to FADA to get sublocade allocated.
You mean
You asked what is.
You mean BHA? Behavioral Health Association?
Yes, for
Okay.
the sublocade. Sorry, it's gonna take a while. So sublocade is injectable Suboxone that is very cost prohibitive for our patients. That's why state has this program. So hopefully next month I can report that we received sublocade allocations.
Awesome. Awesome. Thank you. Any other questions, comments?
I had one, a quick question. Velma, there was just a term that I didn't understand in describing different types of homelessness. What's doubling up mean?
Doubling up is like when somebody give them a couch to sleep, so they don't sleep on the street, but somebody gave them temporary shelter.
Got it. Thanks.
I guess our college kids are all doubling up when they come back home.
Yeah.
Okay, great. Let's move on to Oxford House. Lori, do you have a brief update for us?
Sure, Al. As of December, Oxford House has a total of 79 houses statewide with 661 beds. We are located in 31 cities. And our newest area that we've opened up houses in is Fort Lauderdale. So we have 2 houses there now, and we're looking to get a 3rd one fairly soon. We're also going to be expanding more in the Miami area. So we did have an issue. As you all know, the market is kind of crazy right now with housing, purchasing houses and stuff like that. And so we had one house in Palm Beach County where the property owner wanted to sell the house. So we're in the process of looking for a new house for that property. All those members were moved to existing houses in this area or in the Palm Beach area. So we have our annual state convention coming up in April, and I just want to, let everybody know if anybody would like to, attend that or have more information on it, to just let me know. And then we have had no overdoses since our meeting or since October. So that is the update. And I was asked to kind of go into the incident that happened from I think it was the last meeting or the meeting before, about the girl being asked to leave in the evening time. We have addressed that, and we are doing training to, help the residents understand that it's very important for them to help people find an alternative place to go. As well as we are transitioning one of our existing employees into a resource position for the entire state, so that we can have people, if situations like this arise, then we can have this person working on finding what resources are available in the community for people that may have been, asked to leave an Oxford house. And also I want to reiterate that if you have a problem or there's some issue that pops up and you don't feel like it's right, to give us a call, in that time. So if someone calls you with a situation going on in the house, we have, Elizabeth is there and Chandra is there, and I know you all know and interact with them on a pretty regular basis. So you could always call myself or Chandra or Elizabeth, and we'll do whatever we can to assist anyone that has an issue if it's within our means to do so.
Thank you. Any questions or comments? Thank you. I want to welcome Alton Taylor. I see you've come into the meeting. Welcome, sir. Alton Taylor runs the managing entity facility, DAF in Palm Beach County. Okay, let's move on to, we have to skip the advocacy toolkit again because Nikki Soto was unable to attend the meeting. So let's move on to the legislation. As you all know, we've worked for months along with Representative Caruso and Senator Harrell. And we now have 2 bills that are going through committees, HB 479 and SB 704. And I just want to briefly go over, I had yesterday had a very informative, very productive conversation with Uta Gaziak and all the folks over there at the Behavioral Health Association. They had some concerns. I hope I answered them. I tried to the best of my ability. But I also noticed that in some of the hearings with Senator Harrell and Representative Caruso, there's a little bit of misunderstanding in some of the goals that we're trying to achieve. This is not a very extensive piece of legislation. There are only 3 sections. Section 1 amends 397.403 in the license applications to require that providers list the names and locations of recovery residences which they plan to refer or accept referrals of patients. By plan, obviously, it's got to be something more than just, oh, well, maybe one day we'll do this. It really is meant to be actively upon the licensing. This is where I will be referring folks. The reason we did this, and you all on the task force know this, is a review of licenses throughout the state shows since 2018, South Florida has lost 33% of the component licenses, where the rest of the state is gaining licenses, various parts of the state. We did a review of data that was supplied to us by DCF, along with data that was supplied to us by FAR. And you notice that FAR has 81% of the beds in FAR are in South Florida, the Southeast region, I should say. Okay, so we're losing component licenses. We have a very vibrant certification system here in South Florida, but we were noticing that there was a disconnect in other parts of the state, Orange County, Jacksonville, to name a couple. I believe over on the West Coast, there was some anomalies where there would be multiple IOP and day-night, in other words, intensive outpatient programs, and there weren't any FAR beds around. Now, granted, in other parts of the state, there may be some people going home at night or living at home. But our experience is that when somebody's in intensive treatment, many times they need a bed in a sober home. And we were fearful that that in many parts of the state, because there wasn't a lot of enforcement and because DCF is short-staffed, that without having it easily accessible to DCF or to a prosecutor who wanted to look into this, any provider that was up to no good could dodge the system and feel pretty comfortable not getting caught. So what this is, the Section 1 and Section 2 puts this information in the DCF database instead of internally being kept by the providers themselves, which they're required to do. But when it's in the DCF database, DCF or anyone else, like law enforcement, for example, can look at and pretty easily determine whether somebody's referring or accepting referrals from non-certified houses. What this is intended to do, like much of the legislation in the last 4 years, is to tell folks, hey, it's not worth, defrauding the system. Certified houses are here to stay. If you're going to do it as a provider, follow the law, or you're going to get fined stiffly, or you're going to get prosecuted for a misdemeanor. So that's the intent. Now, with regard to the certified recovery residence administrators, there's a little bit of disconnect here. None of this is intended to out a recovery residence or a sober home, a legitimate sober home that doesn't need to be certified, to stir up the neighborhood or to stir up the local politicians to go after them. None of this is meant to do this. It's not meant to limit the number of beds for sober living that are available. Far the contrary, we're trying to make it so that they're safer and we protect the residents and the people in treatment more so than we have in the past. But there were some questions. I know that Representative Caruso, you shouldered them really well, but there was a bit of disconnect with regard to the recovery residence administrators. People were confusing residents with a T to residences with a CE, okay? And saying, well, you mean 50 residences? And no, 50 residents, that's the limit. Well, why don't you still have a limit of 3, which is in statute now, 3 units or 3 recovery residences. And the reason is a recovery residence can be an apartment building or a converted hotel and can have 150 legally within the zoning and within the community legally be in existence. So you have a recovery residence administrator that has 3 residences, it could be 450 residents. So we wanted to close that loophole. That came from Steve Farnsworth and FAR saying, it's out of control. It's okay to have more than 3 residences if there's 8 people in them, because you can handle that. A few more residences is actually a good thing because we have a hard time certifying, getting workforce together to be recovery residence administrators. But we need to close the loophole that permits 1 recovery residence administrator to oversee hundreds of residences. And so, just wanted to clear everything up, with everybody here so that there's no confusion. I know there's none in the task force, but those who are listening in. And
Al?
lastly,
Al,
go ahead. Yes.
I was wondering if I could interject here.
Sure.
Just to let everybody know, the certified administrators, they've only got so much capacity. And when you try to manage 500 people, you just can't appropriately respond to the residents' needs. And, and you can't maintain proper housing standards. So, we're limiting it to 50. And then under certain conditions, if they apply up to 100 residents. But we had spoken, Al, about limiting the number of resident houses that an administrator can manage too. So even though we look at one side of it where we have 1 unit, but it's got 150 people in it, and we had, the law was 3 units. So they were managing, almost 500 people. What if they try to manage 20 properties with 2 or 3 people in each one, and throughout the county? That kind of spreads them thin too. So I'm wondering, we had spoken about an amendment, and I was wondering if you had given that any more thought.
Yes, I have. Thank you for bringing that up. Actually, I'm going to ask Steve Farnsworth to chime in, because I called FAR and I discussed with them and reconfirmed that there are recovery residences that are hotels converted, et cetera. And then I asked him about, well, what about 3 residences? I mean, now the normal residence has between 8 and 10 residents. I think that's probably pretty much average. There are very few that are more than that. They'd have to be mansions to be more than that. But say a 5-bedroom house could have 10 people, 4-bedroom house could have 8. So what we're looking at is 50. You could have as many as 7 residences. And Steve told me it's so hard. It's not a high-paying career to be a recovery residence administrator. I wish that Neil McGarry was in the meeting this month, because he would concur with this, that we want to have enough of a workforce to take care of all the beds that we have in the state and that we're trying to get certified in the state. Steve was not concerned about having a few more residences as in houses, because that's not really the problem. The recovery residence administrator generally doesn't live at the house. He may at one of the houses, but it's not a requirement. It's just to have somebody that's there to oversee a number of houses. And Steve, could you chime in? Because you said that it would be a bad idea with limiting the number to then limit the residences, because effectively, if you limit it to 3 residences, most recovery residence administrators would be down to 24 or so residents. Steve, want to chime in?
Sure. If you look at the legislation in 397-487 that talks about the requirements of the CRA, what the oversight requirements are, then it doesn't make much sense if you just limit it to number of locations, particularly since you can have like I'm sure you just said, you can have a location that has hundreds of residents to oversee, and you can have one that has 4 or 5. And so what we had to pick a number. This number seems to be reasonable. 50 is enough to where one person can oversee them. We actually think that they could oversee 100 easily, but we would like to have we wanted to have that oversight, because if you have a program that where there's a lot of distance between the residences, then you might need 2 people overseeing 100 people. But if they're all clustered together, there's no reason why you can't, one CRA can't oversee 100. And so that's why we asked for the 50, and then let FAR, through its assessment process, determine whether or not that we can actually authorize 100. But if you go over 100, then we think that they can't really accomplish what is set out in the legislation.
Actually, Steve, the number is 50, and then with when you determine that they can do more, say if it's one apartment building, and you have 2 recovery residence administrators at 75 people each. But let me ask you something, because this is kind of along with the lines of what you're saying. Let me give you a hypothetical, because the legislation says a maximum of 50, okay, is the normal.
Right.
If you saw a recovery residence administrator that was overseeing a house in Palm Beach County, a house in Martin County, a house in St. Lucie County, and a house in Okeechobee County, would FAR have some concerns about that, to the point where they can't reach the maximum 50, that because they don't meet the requirement that they be able to oversee the houses, all the houses, and with such a wide distance between them?
Yeah, I think there's a legitimate concern there, whether or not they can actually accomplish what they're legislatively required to accomplish.
So, so giving you the authority to be able to implement the statute that says the safety of the residents, the ability to oversee. I want to be sure, because I want to answer Representative Caruso's concerns, because those are the concerns that he hears in committee and in the legislature, that by taking out the 3, that doesn't mean that automatically a recovery residence administrator has 50 no matter what.
Right. I mean, right now with the location, your recovery residence administrator could have well over 100 as it is right now. We have situations like that currently.
So in other words, even with the 3, you can have somebody in Orange County, have a house in Orange County, a house in Okeechobee County, and a house in Palm Beach County. And as long as it's 3, they can be anywhere in the state.
That's true. That is correct.
Well, now we have new language, which is the preamble that says they have to be able to meet the needs of the residents. So I guess what I'm doing is just giving you a heads up to think about this, because that would give you the ability to say, whoa, wait a minute. How can you oversee the needs of the residents when there's 500 square miles to contend with? So anyway, food for thought. But that's the reason, Representative Caruso, that's the reason why we recommend that we just eliminate the 3 and let FAR do their job. And if there's a couple of more residences, there still won't be that many residents that they'll be overseeing.
Well, Al, okay, I understand that, and but I think Steve's brought up a whole, and yourself have brought up a whole different scenario now, where we could have that 500 square mile thing issue, and that they can't, effectively and appropriately. Did we want to kind of dial it in and not leave gray area there for subjectivity, and at least maintain
Dial in a square mileage or something like that within 20 miles.
A radius or something.
Radius.
Well, we've had. I know of one situation recently where we had a person call us who lived up in the northern part of the state, asking if she could be the CRA for a program down in the southern part of the state. And we told her, I said, how are you possibly going to be able to oversee these people? How are you going to be able to do what you are required to do,
Right.
legislatively? And so we told her no. We used our discretion.
Okay.
So that's another situation that would fall under that square miles. But I also think that language that just allows FAR to be able to use its better judgment as to whether or not they can actually do what they're required to do, oversee the people in those areas that are laid out in the legislation.
Right, so the wording that we have in here that says the bill requires recovery residence administrators as part of their certification process to demonstrate their ability to effectively and appropriately respond to the needs of residents and maintain standards and all other statutory requirements. That suffices, you believe?
That suffices to me, because it gives us the ability to, to use our judgment, based on our experience, to let them know that, we do not believe that you can do that if, that many miles away, or any other circumstance that might come up that we're not, seeing right this minute.
Okay. Well, I lean on lean on you guys a lot. So I'm okay if you're okay with it.
Yeah, and I think if anybody asks you in committee, that the answer is the statute does provide FAR, and it does, I believe, provide FAR with the flexibility to be able to refuse a certification with an administrator that's spread too thin.
Yes.
Got it.
Great.
Al.
Thanks.
Thanks for bringing
Al.
that up. Any other comments or questions?
Yeah, Al, I do.
Jeff, I was about to ask you your opinion. Go ahead.
No, this is fine. I just want to ask Steve Farnsworth a quick question. Or Steve, is it true that there is a critical shortage of CRRAs in the state?
I don't know if it'd be critical. I think Whitney's on the call. She can probably answer that better than me. But no, to my knowledge, there's definitely not a critical shortage. It might be it might be tough to find one every now and then, but I would say no. I think we have, I know we have a list of CRRAs that are not employed. So I don't think that would be, I don't think that's a.
And what do people do? What do people do when they live in an area where either their CRRA moved or something happens and they can't, because of where they are in the state, cannot readily access a CRRA? Is there any interim procedures or policies that have been established to help that person continue so they're not in violation until a new CRRA can be identified? Or if not, I guess they need to terminate one of their homes. Is that fair to say?
Well, that's it. That with the current law, they would have to, yes. But what I usually recommend to people right at the beginning of the application process is to get somebody certified who's going to be with you. Get your, somebody who's working with you, maybe a partner or a spouse or yourself. Go through the certification process. That way, you don't have to worry about a CRA leaving you, and that's usually what people try to do. But I do not believe there's a shortage of CRAs. I know there's a list of people who are certified who are not employed. And but yeah, I think but that would be my recommendation to anybody, is to get certified yourself so you don't have to worry about that. But we have plenty of people that can go in at least on a temporary basis and cover you. Because the other thing about the law is, I think it's 30. You have 30 days to replace the CRA if your CRA leaves. That's a short amount of time.
Right. I was thinking about that because of people changing jobs and moving. I just wanted to maybe have for future discussions. I think that there's an impression here that CRAs are across the state and covering people various distances, and I don't really think. I think that if that's happening, that's the exception and not the rule. I feel like we're offering a solution in search of a problem. I understand the philosophy and policy behind it, which I 100% adopt and support. I just think that we're making it harder and harder for recovery residences to do what they need to do, because it's my understanding that there's difficulty finding reputable, qualified, reliable, responsible CRRAs in Florida. So I just wanted that stated so everyone can be aware of that fact. And then as we continue to discuss regulation of CRRAs, thanks.
Yeah, I don't think that the intent of this change has anything to do with capacity of available CRRAs. I think it has to do with the ability for the CRA to actually do more effectively what they're responsible in doing. And actually, now that I'm thinking about it, it might even make some CRAs available to work for other programs. If you have 4 houses on the same block with 4 people in each house, you have to have 2 CRAs in the current law. So I'm just saying that very few people are going to have to add more CRAs, but some of them are not going to have to have more than one.
Okay, thank you. Any other comments or questions before we move on? Okay, great. Hey, let's go to item number 5 real quickly. While Dave Ehrenberg and I were in Tallahassee a couple of weeks ago for the first week of session, we all of a sudden got a brilliant idea that we should have gotten 2 years ago. Fentanyl test strips. are illegal. Technically, not that any prosecutor would necessarily prosecute the misdemeanor of possession of drug paraphernalia, but it is a testing device that under the law, current law, constitutes drug paraphernalia. Now, everybody should have gotten, unfortunately this morning, but take a look at this, because there are two bills out there that that involve fentanyl. We didn't want to, Representative Caruso, we didn't want to tack this onto your bill because it would have added criminal justice onto your list of committees that you'd have to go through. So we didn't think that would be appropriate or smart to do. We do have an existing fentanyl bill which increases fentanyl penalties for selling fentanyl within 1,000 feet of a treatment center or a recovery residence. And we asked Senator Brozier, I believe, and also Representative Plakin. They have SB 190 and HB 95, and we asked that they add on an amendment to the paraphernalia bill 893-145. The language is at the bottom of this sheet, so if you could scroll up a little bit. There's another bill actually pending that is Senator Learned, I believe, or Representative Learned. Yes, Senator Jones and Representative Learned. It actually does attack this section to make it legal, but what that legislation does is it just takes out Section 4 entirely. And in the synopsis, we point out that there's no reason on God's green earth that we would want to eliminate as paraphernalia testing equipment that tests the purity of cocaine so that a drug trafficker can cut the product a certain way. No, we want to target this. It also increases the likelihood that it'll become law. Target it and just say, look, substances, testing equipment used, et cetera, for the strength, effectiveness, or purity of controlled substances. And then we say, other than, this is the definition of drug paraphernalia, other than narcotic drug testing products that are used to determine whether a controlled substance contains fentanyl or a fentanyl analog. I got to tell you, with all the stories we have coming in, confirmed and unconfirmed, and some of them are confirmed, where people are buying cocaine or Xanax or Adderall and are dying because they're laced with fentanyl and they don't know it. Having test strips available in a drugstore that you can buy for a couple of bucks would likely save hundreds, if not thousands, of lives, since we know that 5,818 of the 6,089 deaths in Florida in 2020 due to opioid overdose were fentanyl caused. I mean, this is a no-brainer. We're hoping that it does get amended onto that bill, or perhaps we can change the language, amend the language of the other bill to limit it to products used to determine fentanyl. But anyhow, pretty straightforward. Dave and I are pretty excited about this because had we thought about it, Representative Caruso, it would have been in your lap, I assure you. But at this late date, we're trying to get it through as easily as possible. So any comments or questions? I just want to make everybody aware of that. Okay, seeing none. Let's move on to, okay, 6A is, I don't have to do because we have Dr. Atenito from FAU College of Business to do a cost benefit analysis of transport to the JFK North. Now, our data that we have in the task force is Palm Beach County Fire Rescue data. I cannot, Joseph, if you go back and tell Commissioner McKinley that the fire rescue has been, Palm Beach County Fire Rescue has been incredibly cooperative in getting us up-to-date data that we can use to just see. I mean, maybe it's not cost effective, and maybe we have to go another route by opening up another ASU type facility or getting JFK Central or some other hospital to buy into a trauma model. But anyway, with that, I give the floor over to Dr. Atanita. Jennifer?
And with that,
Hi there.
Al, I've got to go.
I got you. You got important things to do there, sir. And
Okay.
keep us posted on how the bill's doing, okay?
Appreciate it. I will.
All right, thank you for everything. Bye.
Thanks. Bye-bye.
Hi, I'm going to share my screen. Okay.
Who sent us an update? So first screen.
Okay, so
Done.
good afternoon. And as Al was saying, this is data from Palm Beach County Fire Rescue. I've been tasked with determining cost effectiveness, which is actually a little different from cost benefit. Cost benefit, the outcome is also monetary. So in this case, we're not looking at monetary outcomes. So we're looking at cost effectiveness, and this is a difficult task because even though Palm Beach County Fire Rescue has been cooperative, the data is limited and there's kind of only so much we can do. And this is a continued work in progress because I think that with ongoing data collection and maybe more sophisticated analysis, we can really come up with some better figures. But I think this is a really good start. And I want to also acknowledge Whitney Van Arsdale from OD to Action, who's been incredibly helpful with this. So the reported concern by Palm Beach County Fire Rescue is the cost of transport to JFK North when other area hospitals are closer. So the research question, I'm going to cover you guys up so I can see this, is Palm Beach County Fire Rescue transport from throughout the county to ASU a cost-effective thing to do? And this is a geographic question, really, because we're talking about a very large county, and it's the second largest county in Florida with over 2,300 square miles, 45 miles from Palmetto Park Road to Tequesta, about 40 miles from Belle Glade to Lantana. So it's a large geographic area to cover, and that's why this is a geographic question. If you're looking at the area hospitals and where they're all located, obviously ASU is here in the red circle, and it is about 6.5 miles to the center point of I-95. So it is pretty central. Even though it seems like it's so far north, it's really not super far north. 13 miles from JFK to ASU, 13 miles from Jupiter to ASU, 14 miles from Wellington to ASU, 26 miles from Delray Medical Center to ASU, and 30 miles from West Boca. That's the furthest one. So looking at this and kind of considering the decisions that the first responders have to make when they're deciding where to transport a patient. So that's the first place I went, was Palm Beach County Fire Rescue. And I looked at their annual report from September 30th, 2020, where they actually announced their partnership with Healthcare District and JFK North Campus to assist patients needing acute intervention related to substance or alcohol use disorder by transporting and referring to the ASU. So, I mean, maybe I consider that a promise, but I know that in implementation, sometimes that becomes more difficult than anticipated. So the first thing I wanted to do is look at where the stations were, where all the stations were located. And if you look at the map on the right, you'll see that there is a large concentration of fire stations, of rescue stations, closer to JFK Central, and much fewer closer to JFK North. The busiest stations are scattered all over the place. I didn't know if that would affect their decision making, but they're kind of scattered around. From OD to Action's patient data, they collect their data from the hospitals. These are from hospital locations. And if you look at where the overdoses are taking place, they are taking place. If you, the densest population, the densest number of overdoses are close to JFK North. So they are taking place close to there. And with some other slightly dense areas throughout the entire corridor and down in the West Boca area. And then this is also Whitney's artwork. She's amazing with these heat maps. I'm always going to her to create a new map for me. These are for multiple ED visits. Also, a similar picture of where these hotspots are. A little bit out by Palms West, a little bit out by West Boca, not a little bit, kind of a lot out by West Boca, but the real hot areas are still close to JFK North, St. Mary's, and Good Samaritan. So about the data, all the transport data was collected from Palm Beach County Fire Rescue over 2-year period, 2020 and 2021. And I kind of drew from a lot of different places. So you have to take some of what I say with a grain of salt, and I'll tell you what should be loosely interpreted and what shouldn't be. Dr. Phillips presented in December 2020 that about 30% of transports were from Palm Beach County Fire Rescue, with the remainder from other municipalities. So these are specifically public transports, not their other types of admissions. So that was from December 2020. I'm sure it's a different number by now, but that was the number then. Only 7% of admissions were transported by Palm Beach County Fire Rescue. That's total admissions. 7% of all the admissions were transported by Palm Beach County Fire Rescue. And that was from Dr. Andrick today. I think it was 7. It may have been 10. It's somewhere close to that. It wasn't a large number, with the majority being the walk-ins. Municipalities that have their own fire rescue are Boca, Palm Beach, West Palm Beach, Highland Beach, Riviera Beach, and Delray Beach. Palm Beach County Fire Rescue does not respond to events within city limits that have their own fire rescue. Now, I have to say, I'm not entirely sure about that statement. I could be wrong. There may be times when Palm Beach County does step in. I'm not entirely sure. Palm Beach County Fire Rescue, the first responders can transport a patient to hospitals anywhere in the county. So it is at the discretion of the first responder to determine where they're taking the person. Typically, it is going to be the closest place. The main reason EMS may choose a more distant hospital is that specialty services are needed. Cardiac trauma, a children's hospital, a burn unit. So that's how the decision is typically made. So this is what the data looked like for these 2 years. Now, it's important to note that this is only patients who had 2 or more overdoses. Okay, so this does not count anybody who just had 1. The total transports were 1,042. This is for the 2 years, with the second transport having 416 second transports, 123 third, 45 fourth transports, 25th, 7 sixth, 5 seventh, 2 eighth transports, 1 ninth transport, and 7 10 or more transports. And it went up to 16 for the year of 2020. They had up to 16 transports. For the year of 2021, they did not report transports over 8. Okay, so I don't know if there were no transports over 8 or it just was not included. So I worked with what I had. So where they're going, if you look at 2020 and you look at JFK, you'll see a good half of them are going to JFK, the central location. The second closest was JFK North, with 16% in 2020 and 18% in 2021. And it seems to me that based on the specialty services, this is a little bit low. This is lower than I would have expected. And then some of the other hospitals receiving these transports are kind of scattered. Bethesda East has a little bit. Boca Regional, hardly any. Delray Medical, 5% in 2020, 3% in 2021. And then Jupiter had 3% in 2020 and what was it? 9% in 2021. Palms West had a little portion, and Wellington had a pretty decent number, and West Boca also. Mostly in 2020, West Boca had received a lot. And then breaking it down into into each of the number of overdoses in 2020, you can see again across the board, JFK central location had a good half of the people, for the most part, go all the way across up to the 5th or more OD transport in 2020. Again, they went up to 16 transports, or 16 overdoses. JFK North, or the ASU, had 20% for first transport, 15% for second, 14.5% for the third, 8% for the fourth, and 0% for 5th or more. Now you'll see the kind of outlier here is West Boca Medical Center with 46% of 5th or more. For some reason in 2020, these repeated overdoses, multiple repeated overdoses were being taken to West Boca. I imagine that there's something about the population in the area. And this is what it looks like visually. It's the same exact data that I just showed you, but if you want a visual look at it, you can see it kind of emphasizes that the number that are being taken to JFK Central. And 2021, you're seeing pretty much the same picture. The difference is that for the 5th or more transport, you have a really large portion taken to JFK, 75% taken to JFK for 5th or more transport, and 0% taken to JFK north for 5th or more transport. And again, it kind of hovers around that 18%. I have not highlighted West Boca Medical Center in this case because for some reason in 2021, they were not receiving that huge spike in transports that year for those multiple overdoses. What we're receiving a pretty nice percentage of the multiple overdoses was Palms West. They were receiving a pretty large proportion. And again, here's a visual that might be helpful. Again, you can see JFK is still leading in receiving these transports. And another one of Whitney's pieces of art, if you want to see it on a map, what it looks like. I did not overlay this map with where the overdoses are taking place, but it's close, but not quite matching up with where they're taking place. So that if you remember the map with the hot spots of where the overdoses are happening, you'll see those were a little bit further north of JFK, Maine. And again, looking also at the map of where the fire rescue stations are located, a lot of them were clustered around JFK, Maine. So some of the preliminary observations from this data were that hotspots for multiple overdoses are in the immediate vicinity of JFK North. The busiest fire rescue stations surround JFK, but are not necessarily closest to where the ODs are occurring. There's an unusual occurrence of 10 or more overdoses going to West Boca in 2020, and the high proportion of transports to JFK seems especially unnecessary considering its proximity to the ASU, which was 13 miles. So in terms of cost effectiveness, the definition is a way to examine both the costs and health outcomes of an intervention. And that's the literal definition of it. In terms of the cost of Palm Beach County Fire Rescue, every time I got on the phone with Whitney, we call this the magic number. Average transportation for an overdose to any Palm Beach County emergency department, we were given this figure, $3,562. It was the only figure that we have, and we don't exactly know what it means, but that's the figure we were given. So that's what we've been working with. And that includes actual costs, salaries, equipment, depreciation, and overhead, and crew being about 61% of that cost at $2,172.82. And the other cost is the time an emergency vehicle is out for an overdose call, which is anecdotally 30 to 60 minutes. And I say anecdotally because I just called friends of mine who are first responders and asked them, and those are the numbers they gave me. So why this time out of service matters is something called unit hour utilization. And stations typically try to maintain utilization of about a third to half of the time their units are out for service. So that's the total number of hours ambulances are staffed and available to respond divided by the total number of transports. And it's a measure of efficiency. They're relying mostly on public funding, with only 24% of their reimbursement coming from third-party payers. So it's really important that for whatever reason, I don't know the details about why, but this is the number that they try to maintain. They want it to be utilized at about half the time. So this was interesting to me. I found National Emergency Medical Services Information System, and you can plug in a lot of stuff and get some incredible information. So this is national information. So I put in incident patient disposition. The patient was treated and transported by EMS, by ground ambulance. And I divided that up between the deciding to transport to the closest facility versus deciding to transport to a regional specialty center. And then in terms of impression of what the problem was, I put all anything opioid related, and it had to be accidental, unintentional. And it came out pretty much the same. About an hour of time would be spent on the total call, but if they went to a regional specialty center, it came out to about an hour and a half. And this is what I kind of expected to see. And not that Palm Beach County is identical to the nation, but we're somewhat average, I would say. So I relied on those numbers, those national numbers. A lot of assumptions were made in this analysis. Effectiveness of ASU. Well, we kind of know based on what's been reported by Dr. Andrick and Dr. Phillips. They offer many unique services that have been described already. This is from Dr. Phillips' presentation and from Dr. Andrick's presentation today. About 4% of the patients leave AMA, which seems incredibly low to me, which is awesome. But I don't know the AMA rates at other emergency departments. They have 80% walk-in. That was from today. That's awesome. Again, that's more voluntary. It probably means more commitment. Let's see, 46% stay at least a full day, 38% admitted 2 to 5 days. Again, shows a little bit higher level of commitment. 29% are discharged to a MAT, detox, or other substance use disorder treatment. And that was from Dr. Phillips in 2020. So those are some of the ideas of effectiveness. In terms of some of the limitations, it's really just geographic, where it's located. We did do a little, and I say we meaning Whitney and I, Whitney really, did a regression analysis and found that patients who were seen at ASU initially had significantly greater odds of subsequent OD as compared with other hospitals. It's a low odds ratio, so it's not a substantial amount, but it was statistically significant. And it controlled for gender, race, ethnicity, and previous substance use history. That said, there could be a million reasons for this. It's like saying correlation is not causation. They could be receiving the most difficult cases. What I don't know is ASU's budget or capacity. So it's hard to make recommendations not knowing that. And in terms of defining effectiveness, I looked at it in 2 ways: getting the patient to the ASU and something we call disability adjusted life year averted. So getting the patient to the ASU, if an OD call is an hour at $3,562, the portion associated with staffing is $2,172.82. So I'm only using the staffing number in terms of for these calculations. Diverted transports 15 miles from ASU will add 30 minutes. The unit is out of service. After the 15 miles, it starts to become less effective for the unit. Cost of staff out of service for the extra 30 minutes would be $1,086.41. So that's half of the other. Diverting 100% of calls that would have otherwise gone to hospitals within 15 miles away would add approximately 300 transports or patients to the ASU in 1 year. Assuming ASU is effective, that number you would expect could decrease over time. If each diverted transport added 30 minutes at $1,086.41, total additional cost for Palm Beach County Fire Rescue could be approximately $326,000 in the first year. Whether that's a cost-effective number or not would be up to Palm Beach County Fire Rescue to determine, but that's one way we can look at this. So that would be based on the cost figure that they gave us. The other thing that we can look at is the disability adjusted life year for severe opioid dependence. Okay, so what's a disability adjusted life year? It represents the loss of the equivalent of 1 year of full health. It's the years of life loss plus the years of lived in disability. And there are 2 approaches. You can either calculate it for an individual or for a population. The individual level accounts for illness, age of onset, and age of death. Now, we're not just looking at deaths, so I would kind of avoid the individual calculation. We're really looking at a population. And that accounts for average age of onset of disease, average age of death, incident count of illness, and incident count of death. I used data from Palm Beach County Fire Rescue that I just reported to you, the Medical Examiner's Office, and Department of Health data. And some of the figures are estimates because that's what I had. And I used this thing called the Global Health CEA Cost Effectiveness Analysis Registry. And based on the data that I've been given, 38% of patients seen at ASU were 31 to 40 years old, and 22% were 21 to 30 years old. So I selected the age 33 to be the approximate median, which was kind of interesting because Steve also mentioned the age 33. So I was like, okay, I guessed pretty well. Median age of OUD disease onset is 23, and age of death from opioid poisoning varies greatly by gender, dramatically by gender, with the average being about 36 years old. The disability weight given to severe opioid use disorder disease is 0.697. And that disability weight is determined by a lot of previous research, where you could look at like stage 4 liver cancer being close to a 1. Years lived with the disease at the time of arrival at ASU would be 10 years. That's the difference between 23 and 33. So looking at the DALYs at different population levels, if you look at the county level, county population data, and this is overdoses, non-fatal and fatal overdoses. And so those are the calculations the data I used. With that number, that magic number of $1,086 for the extra 30-minute drive, the number of disability adjusted life years for the entire county, assuming that the Palm Beach County Fire Rescue is driving anyone in the county to ASU for a half hour, it's 33,471 DALYs averted. And that comes out to 3 cents per life year gained, which is incredibly cost effective, right? 3 cents for each life year gained. That's living in good health for a year. All county hospital transports by Palm Beach County Fire Rescue using their data is, again, the magic number divided by 10,786 DALYs averted, right? Life years that could have been lost. That came out to 10 cents per life year gained. Every time you go smaller in the population, the cost gets a little more expensive. So for ASU transports only, again, using the Palm Beach County Fire Rescue data, it came out to 2,156 DALYs at $1,086 for that extra half hour drive. And that comes to 50 cents per life year gain. That's for the 30. So that's the number we really want to look at. It's about 50 cents for each life year gained for that half hour drive. At the individual level, everything changes. That's why we don't use the individual level data. But if you were to drive one person, they would gain 54 DALYs based on the age of onset of disease and the potential age of death. That would cost $20 per life year gain. It's still not considered very expensive. So what needs to be kept in mind for this analysis is that it assumes that the program has perfect success. Of course, we know nothing does. According to SAMHSA, a SAMHSA review of specialty emergency departments for overdose, they only looked at 3 because there aren't very many. About 60% of patients remained engaged in care after 30 days. So that's pretty promising. Odds of lifetime recovery are not known. And a study in the Lancet found a strong cost effectiveness of hospital-based intervention. So there's good hope, I would say, for hospital-based intervention and specialty emergency departments for overdoses, but we don't have enough data yet because this is a new model. So some of the options that came to mind for me in doing this analysis, that it may not be cost effective to divert transports from hospitals more than 15 miles from JFK. The unit hour utilization could be too high for Palm Beach County Fire Rescue because the time out of service could double. An argument could be made that the ASU is a specialty service, like a specialty stroke center or burn unit, providing care unavailable at any other emergency department. Depending upon ASU capacity and budget, you could divert more calls to ASU from the neighboring hospitals like JFK, St. Mary's, Palm Beach Gardens, Good Sam, Wellington. I didn't put Jupiter on there, but Jupiter would be within that 15-mile. Other hospitals are beginning to provide some more intensive overdose services like Jupiter, and this is what I've heard anecdotally, and you guys might know more. So ASU could potentially serve as a training program to assist other hospitals in expanding services, or you could create, like you're talking about, creating a South ASU center, which I didn't even know you were already in the works talking about making that happen, but it really does seem like there are enough overdoses happening in the south end of the county to possibly warrant that, depending on budget. So that said, that's what I have. And I am going to, I don't know if I stop sharing, then maybe I can see you all again. So that's what I have so far. And I'd really like to continue forward with collecting more data and more sophisticated analysis, and ideally, and selfishly writing this up for publication.
Yes, thank you, Jennifer. Any questions or comments from the task force?
I have a comment.
Yes,
This is
Dr.
Lori
Vinacore?
Vinacore from the Alliance of Delray. Hi. I just want to commend you with a comprehensive, detailed study and analysis. The data is excellent. And please, Dr. Antonito, continue with this because this is very helpful for all the work that the task force does here. Thank you so much.
Thank you. I didn't realize how interesting it would get. I honestly started out, it was daunting. And as I dug in deeper and deeper, I just kept learning more and it got more and more interesting as I went forward and learned more about how fire rescue works.
By the way, I am president of the Alliance of Delray, but I'm also president of the board of the South County Mental Health Center. So we thank you.
Just giving this some thought, Joseph, you know, if you could, you know, discuss this with Commissioner McKinley. You know, there are various ways we can go with this. Well, that's part of what the exercise is to determine whether it's going to be cost effective to have fire rescue, you know, get more resources to transport more people to North County. Not North County, JFK North. Or perhaps, just like the county was instrumental completely. And John, you know, you back me up on this, but and Belma, Dr. Andriek, you know, the JFK North trauma model could not have come to being without Palm Beach County anteing up a substantial amount of money to make it happen. And maybe the direction we should push toward is to get the same, once COVID subsides, which let's all be optimistic about this becoming an endemic cold rather than a pandemic, you know, disease. But eventually have that conversation, hopefully within the next 6 to 12 months, to bring about whether it's going to be JFK Central or whether it's going to be, you know, I don't know what one of the other counties and hospitals in South County. JFK is the likely candidate, but to open up a second unit, and it would have to be funded, and the hospital would have to be able to do it financially. So, I mean, these are things to think about going forward. And we'll have this conversation continuing on in our future meetings. So I don't know if Joseph, you want to comment on that, or John, or Dr.
Yeah,
Andriek?
no, I just want to say thank you very much for having this presentation, and Dr. Antonito for the great analysis here, and Commissioner McKinley wishes she could have been on today. She was hoping to be on today, but we have a workshop that's going very long, talking about another very important issue right now, actually affordable housing, workforce housing in the county, which is directly relevant to this as well. So I will brief her after the meeting concludes. And I know that she's very interested in expanding the ASU where appropriate. So this kind of data will be very helpful in helping that conversation move forward. So thank you again very much.
Sure, great. And you know, maybe it might be beneficial to actually do this presentation in front of the county commission. And maybe we need to tweak it a little bit for the next, because we're going to get more data from Palm Beach County Fire Rescue as far as the individual hospitals that have multiple overdoses. And that, you know, that may be something that we could consider having the ASU and FAU, Dr. Antonito, to present to the commission. But anyway, food for thought. Thank you.
Al, I had a question.
Alton.
Yeah. Whenever there is a discussion about putting an ASU in the southern part of the county, we certainly like to be involved. You know, we have a public detox, as you know, down there, where you don't have that in central and south. I mean, central and north. And I believe prior to COVID, we were handling as many walk-ins as the ASU was, just in that part of the county. So we just want to make sure we're utilizing resources carefully and appropriately, and making sure it's clear how we will work together if an ASU is put down there.
Well, thank you. Thank you for that, Alton. And you know me, I am totally invested in having all the separate silos meet together and become a much more vibrant and a bigger force. So thank you for that. I think that's entirely appropriate. Any other comments, thoughts?
I would like just to comment now. Thank you, Dr. Antonito. I think it's a great presentation. I think next step would be that we meet internally. We have Chief Alice and our team. I would like to kind of really dissect this. I think the next step is also to talk to Fire Rescue to show them this, to get their input. I think this is a fantastic start. I think we are closer to add to that Lancet study, real good studies from our neck of the wood. I think this was a long time awaited input from academical analysis. And this is really fantastic analysis. But I think that we need to kind of see what Fire Rescue says about all those regions and maps and things. They're very, very sophisticated in their own data, and like to kind of just cross-reference that. I think we're going to learn a lot from just giving them this presentation and hear what they think. And let us work internally to kind of maybe group first with the Fire Rescue Owl before we go to kind of wider circles of county commissioners. I'm very curious what Chief Coyle and Chief Duran thinks about this analysis. So I would suggest that we kind of have internal presentation to Fire Rescue, and then work a little bit more on some data that are from 2020 and things. But I think this is fantastic direction and very excited. Those heat maps are also very interesting. Maybe we don't need the South, it's very interesting, really. And I'm looking forward to analyzing that more and more.
Thank you. I fully agree, having the conversation also with Palm Beach County Fire Rescue and maybe also OD2 Action, because they have the hospital level data. And if all of us got together, I think that we could elevate this information.
Joseph, can you facilitate out of Commissioner McKinley's office to maybe, and Lord knows we don't want to be, confrontational. I know that that sometimes when groups like ours approach a group like Palm Beach County Fire Rescue, they're checking their pockets, to make sure that their wallets are still in it when we leave. I get it that we can work together. This is not a presentation that says the best way is to have the longer ride, but it's just a conversation that we ought to have. And maybe that's a great idea. We can talk, John, you and I, and Commissioner McKinley could talk about this along with Jennifer, and maybe set up a presentation in a couple of months for Palm Beach County Fire Rescue. Just a thought.
Yeah, no, I'll talk to Commissioner McKinley about that. I do think it's a very good idea to bring them in and have that consideration. So I'll talk with her about it and we'll go from there.
Cool. Great.
Al, and I just want to share for the audience, not to lose from your side, that the healthcare district will have within 2 months our own transportation, interfacility transportation. The JFK specifically is placed in the COPCN that county approved. So everything to and from JFK North, our own non-emergency transportation will be available, including interfacility transfers. So that's something that is really exciting coming on horizon to resolve some transportation issues.
Wow, that's interesting. That's really good. Ariana Ciancio would she's probably applauding right now with her mute on. To have transport is a key.
So this is MADIX, right? This is equivalent to AMR, right? Non-emergency transfer that is actually approved because there were Lakeside Hospital issues with a long wait for the transfer. But because of Commissioner McKinley passion for addiction, she suggested and commissioners approved that only coastal transportations that our transportation can do is to and from JFK North for the ASU needs. So I'm just that's kind of huge addition to this orchestrated efforts.
So Jennifer, that probably is going to mix into your analysis, the availability of non-emergency transport and how that affects the situation. But let's move on because I want to get to, we have two more presentations, and I hopefully we can get through and end the meeting on time. So let's move on to the OD to action. Whitney Van Arsdale, you're going to give us an update on the data that you've been able to collect in Palm Beach County?
Yeah, let me just go ahead and share my screen.
I love share screen.
All right, should be on the right screen, it looks like. So hi, those of you who don't know me, my name is Whitney Van Arsdale. I'm the biostatistician here at the Florida Department of Health for OD2A. We've been working on our 2021 data, kind of compiling it and getting it ready for a report. So the first thing I want to mention is that the data is only going to be for the first 6 months of 2021 non-fatal overdose surveillance data. We hope to have our full report by March. I believe we should have it done. And then some new changes that we have for 2021. We expanded our overdose surveillance to now include stimulants, benzodiazepines, and novel psychoactive substances. We are also able to link patients' data to EMS reports, so we can have a little bit more of what's going on before they get to the hospital, which has been really helpful as far as like Narcan and pre-hospital interventions and things like that. We have also added Wellington Regional to our list of partner hospitals, and we had JFK Maine, and now we're kind of took a step back, and now we're in talks with a data sharing agreement that should be completed soon. And then hopefully our goal is to start for our 2022, including JFK Maine data. And then of course, with COVID going on, we added some information about COVID infection rates and the vaccination status. So the chart you see here represents the number of suspected overdoses that were identified through Essence, which is our syndromic surveillance system, compared to the number of records OD2A collected from each hospital and the number of records that met our case definition and that were included as a suspected overdose. 697 non-fatal overdose medical records were analyzed for this. And here you can kind of just see the proportion of what is happening to what we get to what is actually considered overdose for us. Dr. Andrick mentioned earlier, I think it was like, wrote it down, like 8% of the visits to the ASU were for overdose. So like that would be reflective here. You can see the JFK Medical Center North, the medium blue bar is really, really high and the dark blue bar is really, really low. That'd be about the 8% of the overdoses that we got. The hospitals with the lowest proportion of data that we received were Bethesda's Lakeside and JFK Maine. We are working to mitigate the Lakeside. They only have a few records a year and they had some turnover. So we kind of missed that data with the new staff. And JFK Medical Center should be getting on board soon. And then all we will have left is Bethesda. 36% of the reporting overdoses indicated heroin use at the time of event. Other drugs that were commonly ingested included benzodiazepines and marijuana. Both were 26%. A significant portion of the opioids involved overdoses did not include the type of overdose. It was just left as opioid unspecified. And this could be for a huge number of reasons, as far as they're not sure what they took. Maybe they mentioned it and it just wasn't recorded in the medical record. But for our purposes, we don't know what kind of opioid, only that it was an opioid. And this is very similar to what we saw in 2020, where we had the majority was heroin, and then a smaller portion was opioid, and beneath that would be fentanyl. We also had 17% of the opioids were used intravenously, and 30% of that had missing data, so we weren't really sure what's going on. So we think that number might actually be higher, or that the reporting of IV drug use is low due to stigma or fear of persecution for paraphernalia, things like that. No surprise here. The overall sample was mostly white, non-Hispanic males aged 25 to 44. But it does get a little bit more interesting when you start to stratify it by type of drug. You can see the skew here for the opioids and the benzos. It's actually a little bit more at the benzo, where that higher age has a larger proportion of overdoses occurring. So that makes us think that this is a little bit different than what we're used to with that 25 to 34, 44 age group. This is going to be a little bit older. Here we have the race and gender, again, stratified by drug. You'll see that the benzodiazepines tended to be more female than opioids and stimulants, and that stimulants tend to have a higher percentage of both Black and other races compared to opioids and benzodiazepines. And this is going to be really good later for targeting regions of our county where we can implement interventions that will do the most benefit. So knowing the populations that are using which kind of drugs will help us target those interventions. The temporal trend for the first 6 months of 2021 showed an overall decrease from the start of the year, but we know that our preliminary data for the whole year of 2021, it does go back up. So it looks pretty hopeful, but I read the end of the book and it's not good. So I think I'm funny sometimes. A third of our patients were found to have unstable or transient housing. We talked a lot about this already today, where it's homeless shelters, in and out of rehabs, prison, jails, hotel, motel, couch surfing. And that's really going to affect their ability to engage in meaningful recovery. Most of the patients we saw were uninsured, but white patients were more likely to have private insurance than Black or other races. This is especially important with the insurance because the type of insurance you have can and does affect your treatment options. For instance, 1 in 10 drug treatment facilities in Palm Beach County accept Medicaid insurance, so that really limits the treatment options extensively. Additionally, most of the sample was not employed at the time of overdose, and the largest proportion was unemployed adults, and that accounted for 44% of the patients. Here we have the criminal history section. Almost half of patients had a prior arrest for drug possession, and about a third had an arrest for possession of drug paraphernalia. Hispanics were 3 times as likely as non-Hispanics to have been arrested for drug possession, even after we controlled for things like age and race. There were other significant predictors of drug possession arrest, including Black, which was almost twice as likely as white, and males, which were about 50% more likely than females to have an arrest. The data from 2021 so far shows that we've actually had a decrease in the proportion of patients with Hep B, Hep C, and HIV. And this might be due to a number of things. For instance, we're including the benzos and the stimulants now, which aren't as strongly associated with IV drug use as opioids are. So that might have been why we see this decrease. We saw an increase in MRSA infections from 1 to 4%. So that's something we're going to keep our eye on. And we're also talking about how we can expand our surveillance to include other infections as well. It's just a logistics game pretty much. So COVID, this is one of the new variables that we started looking at in 2021. The overall infection rate was 13% higher in patients compared to Palm Beach County overall. You can also see their vaccination status is way down comparatively. About half are vaccinated compared to that of the Palm Beach County with 38 versus 71%. And then all the way at the bottom, you can see the additional dose, also known as a booster. About a third is likely to get a booster when you have a history of substance abuse. So it's really important. They have so many vulnerable living conditions and health conditions. So we really need to focus, I think, on getting them vaccinated and getting them healthy as well, not just mentally and substance abuse, but also physically. And then we have our clinical overdose information. The mode of arrival, most were brought in by fire rescue, and about 12% were brought in by a private vehicle, either a friend or family dropped them off, sometimes a stranger. And then we had about 1% arrive by police transport. About 30% had a history of IV drug use, 80% had a history of substance abuse, 30% had at least one prior overdose. We suspect that number is much higher. Again, the data, how we collect it, it's what's recorded in the medical record. So if they don't mention it, they don't record it, then we don't know. But we know at least 30% have had an overdose. And then 14% have been in MAT before. And that's a number that we're really focusing on because I know there's a big push in the county for Suboxone in the MAT program. So we're really trying to keep track of that and seeing if people are getting linked to that care. And then, of course, naloxone or Narcan is such a big harm reduction. So 3 in 5 of the patients needed to be revived with Narcan. The average total milligrams of Narcan needed was 2.5 per patient. But that includes a mixture of IV Narcan and intranasal as well. So we're working on refining our data collection to be a little bit more specific because I think you do require less milligrams if you're doing IV versus IN. So 1 in 25 had an active prescription prior to the overdose, meaning that they already had Narcan at home. And then only 1 in 10 were prescribed Narcan upon discharge. So we really would like to see that number up. You know, it's even if they leave AMA, it's a really quick, easy thing to get them Narcan, to give them that harm reduction and kind of give them the opportunity to get help later on if they choose. Only 10% of patients were referred to MAT. Most of it was from JFK North as expected, but we've also seen an uptick in MAT referrals throughout the county. So that was really good to see from our end. Here you can see our toxicology. Unfortunately, we're still only getting about 30% of the records have their toxicology listed. They might have done it, but we can't report what we don't know. So this is just what was in the records, with the largest percent being benzodiazepines, 13% overall tested positive for benzos, and 5% tested positive for opiates, which would screen for those naturally derived opiates like morphine and heroin. Here we have our toxicology continued with the percent positivity overall and by drug reported. So the dark blue bar is the percent positivity of toxicology results overall. So of all the people who were tested, the ones that tested positive for heroin, fentanyl, oxy, etc. And that light blue bar is broken down even further to the ones that were tested and reported heroin use. Did they test positive? And we see that with fentanyl and amphetamines, 100%, if they reported fentanyl use and they were tested for fentanyl, it came back positive. So this kind of tells us a little bit about what they think they're taking and what they're actually taking. Again, with 30% toxicology results coming in, we really want to see those numbers way up to get like a good, meaningful analysis from this. So please interpret with caution. And then overall, this is the beginning of our 2021 full year report. This is all Essence data, so it's de-identified. It's very basic in what we can pull from it, but you can see 4,603 suspected overdoses were identified in 2021, according to our Essence surveillance syndrome. For all drug and opioid, you can see that they are similarly laid out in the region, and that's probably going to be because opioids made up the majority of overdoses. But when you start to look at things like the benzodiazepines and stimulants, you'll notice some very strong regional differences. You'll notice for the benzos, that it's more concentrated up towards Palm Beach Gardens and Jupiter, and then in that West Boca, West Delray area. Stimulants as well, you will see a concentration right there, Riviera Beach, West Palm Beach, and all the way west at Belglade, Pahokee. And this is all adjusted for population, so we can more easily compare zip codes of high population and zip codes of low population, really just look at the rates of overdose. So I think moving forward, leaning on these visual aspects and leaning more into visually displaying our data is going to really help our communities by showing them where the gaps are. And if we could show you on a map, this is where we need to focus, I think that we can do the most impact and hopefully help a little bit. So be sure to look out for our full report coming soon. And if you guys have any questions, let me know.
Before I open it up to the panel, Whitney, thank you very much, first of all. And we look forward to having you do the annual report, either at our March or our May meeting, whatever is best for you. We have openings in both. I just had a couple of comments and questions before we open it up. Going back to slide 4, I noticed that JFK was not represented on the hospital reports. And I wanted to mention, and I think that you're in the process of an MOU with JFK Central, but it's not one of the reporting hospitals right now, correct?
Correct. And that's
So-
why you'll see, you can barely even see the amount of records that we've abstracted because it's only ones that we happen to get for other diseases like Hep C. They might fall into our lap, but we're not actively collecting right now.
Yeah, and I just wanted to make that point so that people didn't look at that chart and say, well, that doesn't make any sense with the last presentation of where JFK was the 50% of all opioid overdoses were at that hospital. So I just wanted to make sure everybody knew that. The second thing is, until we have testing for fentanyl, I think you would agree that the data is going to be incomplete because unless there is drug testing, then it's self-reporting. So somebody comes in with an overdose and they say, well, I had Xanax. I overdosed on Xanax. Well, unless you test, you're not going to know that the Xanax was laced with fentanyl when that's what drove the overdose.
And we do
Same
see
thing
that a
with
lot where
cocaine.
people come in with the cocaine, the Xanax, but they're responsive to Narcan. So we're like, okay, we know there's more to this than just the Xanax or the cocaine, but we're not getting the test to confirm it. So
Right.
it's really, we see that on our end and we're pushing for it, but
Oh, you're like one hand's tied,
I know.
But the reason I bring it up is we should all support this legalization of fentanyl test strips because everybody can have them. If the urine test in a CVS is like $12, what do you think a test fentanyl strip is going to be? It's going to be under 10. So that might be the single most important thing to be able to drill down and identify on a much larger scale. Sorry, I unvideoed myself. To drill down on a much larger scale and be able to have that data in your lab. And by the way, thank you very much for all you do and all you share. Because I don't believe that Dr. Atenito would have had half the value of her presentation without folks like Palm Beach Fire Rescue and you all. So thank you.
Yeah, no problem. And I hope that our maps, especially with the fentanyl test strips, that's why I think the benzodiazepine stimulants county maps would be really helpful because those are specifically targeting areas where they're not probably intentionally ingesting fentanyl. Whereas if you look at the fentanyl or the opioids region, a lot of people do know that they're consuming fentanyl, or a lot of people are just consuming opioids. But if you target, the stimulant benzo regions, you can kind of help cut out some of those unintentional ingestions.
Great. So any
So I just-
other questions or comments? Yeah.
I would like to
Velma?
talk about it, Al. Those are two different things. One is, and if I understand well, legislative issue that you have is a test strip that you test the fentanyl before you use the drug So you know there is a fentanyl in, so you know that you have a higher chance to overdose. What we are talking here about is a medical test in emergency room. When you have the urine drug test, they don't have a fentanyl. Fentanyl is still not standard panel on the urine dipstick that the medical grade test does. So I think that there is a value that we try as a sober test, I mean, whatever new name is, like this is very powerful group of people. If you write a petition or a letter to the all CEOs of all local hospitals to add this medical grade test to the urine would be solution for this OD2A data, right? Those are two different tests, one, to my understanding. But I think that the legislative changes proposed are about to have the test for the drug. Am I saying right or no?
Yes, it's a specific
This
test.
is different
for fentanyl.
issue. This is a medical grade test that you do the urine.
Got it. I see the difference, but either way, you know, it's a half a loaf if you can get the less accurate. It's kind of like the rapid COVID test as opposed to the PCR test.
No, this is the test of the drug versus this is test of the urine.
Got it.
And it's a medical test versus like
Oh, I
really
see.
kind
I
of street
see.
test.
A fentanyl test strip would not work in a hospital because you have to be able to test the urine. Thank you for that. That is
Well,
absolutely.
they do have one. In fact, we use it, but we just use it for internal purposes because it's not rated for legal diagnostics yet. It's more for criminal justice, but it is fairly accurate. But we couldn't use it like for cases that go to court and so forth. So that's why it's not widely used. But the company says they are working on one that'll satisfy the diagnostic and legal purposes. I had just one quick question. On your suspected overdose, how are you calculating that?
So when we get, we request all records that come through from the Essence query. It's like a pre-developed query that kind of, it's less specific, so it's very sensitive. So it will capture everything and kind of capture a lot of false positives that might not actually be an overdose. That might just be, walk-ins for detox or sterilization, things like that. So we receive the records and then we go through and they have to meet a clinical and lab case definition that we developed to really assess. It's not a perfect science, a lot of it is strong speculation, and that's why we kind of include all of them and we blanket that as suspected drug overdoses. So all of these are suspected drug overdoses. Did that answer?
Yes, it did. Thank you.
Okay.
And then I just want to confirm that.
Al, can I jump in here?
Who's that?
John Ulick.
Oh, yeah, sure, John. Go ahead.
Thanks. Whitney, once again, thank you so much for your work and as well, Dr. Antonito. This is incredible information desperately needed. A couple things, Whitney, if you might be able to expand or expound on it. Curiously, marijuana as an overdose event, 26%. Marijuana is not supposed to be harmful. So is there some related lacing, i.e. fentanyl or some other?
These are the drugs involved in the overdose event, not necessarily the overdose classification. Like for instance, we didn't study specifically marijuana overdoses, but we did include if they said that they smoked marijuana and did some coke, we just like grouped it all together. They did coke, they did marijuana. So you can kind of see the polysubstance use, I guess, what's going on there.
Okay, all right. So not specific. So thanks so much.
Not specific, but I know for a fact that a few of them did get like looped in where they were smoking marijuana and now they need Narcan. So obviously it's not just marijuana. So we're working on how to better identify those and report them back out to you guys.
Excellent. I also noted you categorized, and frankly, this is could generate, and it should generate, some serious thinking in terms of predictors, housing stability being a predictor to long-term recovery outcome. So you categorized sober living and halfway as unstable housing. I'm very curious, what your thinking is there and why it was categorized that way.
Basically, our thinking here was we were seeing a lot of people who were just getting kicked out of a sober home, or were there for a week or there for a month. We didn't really see any long-term sober living. So we just, it kind of felt more transient than anything. And again, it's really hard to assess people's living situation just reading about their medical records. So it's a hard thing to do. So we just kind of grouped it in. I think our 2022 data, we kind of separated out to be more homeless, transient versus in treatment, just maybe switching around a lot more. So it's a finessing thing, I think.
Excellent. I really appreciate that. Again, I really hope that stimulates discussion, because obviously historically we measure treatment outcome by successful discharge, and then these burdens of housing stability, and employment virtually rest squarely on the backs of the newly recovering person. And when we lapse, we get to conveniently blame the individual and not a system that hasn't really meaningfully addressed this.
And that's why we also include the criminal history, and we're so strongly reporting that. It is pretty good data. I would say like above 95% reporting for that criminal history data, but that's also a strong barrier. People have, arrest or jail time for drug possession or drug paraphernalia possession. It's going to inhibit them getting, maybe some housing types or.
Yep. No, you're look, absolutely. So systemically, legally, in all kinds of which ways we've created these barriers to longer term recovery outcomes. So, and I just have one last question. It's on the benzos. Is there any way to determine, Whitney, how much of that was legally prescribed? As we know, as people get into the treatment environments, they're often, being scribed benzos, et cetera, et cetera. So
excessively prescribed benzos.
Yeah. Could you do, is there a way of determining how many of those were legal scripts or no?
We have, again, that's really hard passively. We can do it where we look at how many are overdosing on benzos and how many actually have a prescription for benzos. A lot of them just don't report. They're just not reporting in the medical records. So we're not seeing a lot of their prescription history. So it's something that we're trying to figure out, but with so much of it being prescription and then a very large portion being illicit street Xanax, it's really hard to confidently say one way or another.
Does PMP, prescription monitoring program?
PDMP, we don't have patient level access, so it's really hard to connect the dots. I know patient level is like a really big thing and it freaks a lot of people out, but it's so helpful to be able to really get all these underlying factors. I mean, we know that there's overdoses occurring, but we don't know how and why and when and what led up to it and how certain events can influence it one way or the other. So we're really pushing to integrate all these different data sources and talk more and work together collaboratively.
Excellent. Thank you again. I just can't thank you enough for the good work that you're doing.
Thank you.
Whitney, if I can just bootstrap onto what John was talking about, specifically benzos or benzodiazepines. I'm going to hypothesize, I'm going to go out on the limb. Very few people are overdosing by taking too many of their prescribed Xanaxes, unless it's intentional or semi-intentional. I mean, I'm not a doctor, but I'm trying to use some common sense here. We see so much polysubstance ODs that involve fentanyl. If you're getting your Xanax on the street, for example, the likelihood is there's fentanyl in there. And that's why it's so critical that at the hospital, they need to medically, as Dr. Andreek pointed out, they need to medically test for fentanyl, or we're in the dark here. You know, I just, somebody, you know, people with more knowledge than me medically can tell me, no, it's very easy to overdose on Xanax, for example, which is one of the more common benzodiazepines, but I don't see it unless somebody's trying to commit suicide. It's got to be. Marijuana is another one that we mentioned, that nobody's going to the hospital for marijuana unless it's laced with something like fentanyl. And the state numbers of overdose deaths at 95.5% bear out that fact. I don't have the numbers in front of me, but I can look them up on how many pure benzodiazepine overdose deaths there are.
Less than 1%, I think. I think less than 1%.
I'm looking at Dr. Moran, like I think he wants to jump out of his skin, but benzo is serious addiction.
It's
you know,
an
don't
addiction.
underestimate the importance of benzo in our community. But for the record, so what John said, how many are legally prescribed? There is no medical condition unless you have status epilepticus that your doctor should prescribe your benzo. So one is thing legally prescribed, one is a bad doctors who are still prescribing benzo.
We have most of the largest portion of controlled substances prescribed are benzos, and it's really frustrating to see just how many and how many they're co-prescribing with Adderall or Ambien or other benzos on top of muscle relaxers. I don't think I can say any opinions on that.
I want to say anybody who prescribed benzo should be on our radar.
All right.
Anyway, but the point is, I want to go back to fentanyl. I think that this group has really a lot of credibility in the community, that we request from CEOs to local hospitals to implement fentanyl urine dipstick. It's a medical grade test. I heard Alton talking about it. But JFK North and South it's a CLIA wave test. Our clinics have a fentanyl test strips. Some hospitals has it, but majority don't. It's a medical test that needs to be in each emergency room as we speak. That's the one thing. The other thing I want to talk about regarding Whitney, your presentation, when you talk about prescribing Narcanes, I just want to share that when you see the news, actually, we start looking into this when we hear news that City of New York has a vending machine for Narcan, and I start looking at how they can do it. Actually, turn out to be, if you're a medical provider, you can have a standing order for Narcan. Starting this Thursday, we're going to distribute Narcan in the baskets in our pharmacies. Anybody who wants that, no question asked, patient or not patient can come and grab a Narcan spray. So that's another approach, maybe when we reach out to local emergency rooms, that they can, I don't know what is the legality of ER standing order for Narcan, but we are starting that this coming week.
That would be amazing.
That's great.
So just from the legal standpoint, if a medical provider can have a standing order, state of Florida can write a standing order, like health departments can write the standing orders, and kind of really have a very, very low threshold for that. Because I find that if 1 of 10, discharging from ER, if you need to give them prescription, they need to go to pharmacy, we know they're not going to do that.
Mm-hmm.
And
No, I totally agree.
Narcan is offered to every client that walks through DAF's doors. Many refuse it, but every client is offered free Narcan, and their parents or loved ones. All they have to do is just take one class, one-hour class, loved ones, not clients. Clients can get them upon asking. So if they come in for an assessment, at the end of that assessment, they're given a flyer and Narcan. And if they refuse it, we just sign they sign a document saying they don't want it.
I wonder how much of a barrier that is, requiring a class to get
prescription,
Narcan.
no signing, just give them in a free for all. That's the kind of eliminating any barrier.
Like condoms.
Yeah,
Exactly like a condom.
All right,
Yeah,
that,
if loved ones want it, we also give them, and they don't want to take the class, then it's available at certain pharmacies for free. And so they're given other options to do that. We give clients a 15-minute, at the end of a session, they get a 15-minute overview of Narcan, how to use it and so forth. And so that's how we do it at DAF. But everyone can get it and can get it as often as they request it.
okay. We've got to move on. We've got one more presentation from Steve Farnsworth and FAR on respite and post-recovery support services. We don't have very much time, so Steve, let me hand it over to you.
Okay, thanks, Al. We the intention for this meeting is really just to kind of get people thinking. The way I'm defining a respite would be a place where people could come, they could walk in, they could be brought by the police, they could be brought by family members, friends, the moms that we have in our county, sponsors. They could come, anywhere, any way they could walk in, similar to what they do at the Lewis Center Annex for homeless, but with some differences. That location is really not ideal. Plus the fact that it used to be a jail, so it looks like it, a jail. It feels like a jail. But but a similar type of model where people can walk in, they can get treated with respect, they can get a place to get cleaned up, some clothing, some food, and get assessed. Assessed for appropriate level of care. Some of these people might only need to be there 24, 48 hours. They to go to wherever they already have set up, like a recovery residence, or certified or not. Just a place where if they have a place to go, but they need a place to stay for a couple of nights just to get off the street and be safe and be assessed. Not only is it a nice way for us to assess them and their needs, but it also is a nice way for us to actually assess, or an effective way for us to assess the need in the community. The other thing that we, a lot of in certified recovery residences, when you return to use, you can't stay at the house until you can provide a clean urine. In most cases, we actually want you to go to a different house. We don't want you to go back to the same house. But regardless as to where you're going, nobody's going to let you in until you can provide a negative drug screen. And so that's a place where they can go for that purpose too. On the other end of housing, I'd also like to see some kind of recovery support services for people who are graduating from recovery residence, if graduating is the proper word or not, but going back into the community, preparing to go back into the community. I think that we can do that stuff easily without a whole lot of funding. But the big deal is the respite at the beginning for people to so we get people off the street, get them safe, and get them directed towards the resources that we have. I've had Frank Rubito, the president of, I believe that's his title, president of WestCare, which has facilities in I think 16 different states, but they have 6 different facilities here in Florida. One of them being Susan B. Anthony, that is now called Village South, but they did a really good job of remodeling. And I've toured that place. It's amazing what they've done with it. He's stated that he's willing to buy, rent, whatever it takes, as long as we can make the numbers work for him, because he can't lose money because they are in business. And if that's not an option, he's even willing to sit on the council or the committee to share his experience and help us put something together that that we can make work. I've had a couple talks with James Green about it from the county. John Hewlett might want to chime in a little bit. We've had these discussions, but we need a location, and we need some ideas, and we need support probably from this body as well as many others. But I think the attempts that we've made at respites in the county prior to this are not the same kind of respites that I'm talking about. I'm not talking about a place like Ted's place was. I'm talking about something more similar to what's going on out there at the annex by the fairgrounds, where people can come in in any way, in any condition, and we can direct them in the proper direction for their appropriate level of care. So that's pretty much all I want to say about that, but I'll be glad to answer any questions. But like I said, this is something that I'm pushing on. I'm just really just trying to get people thinking right now. I don't really have any more than that. Thank you.
Well, let's circle back. Let's circle back in either the March or the May meeting. Everybody give it some thought. I mean, I'm trying to wrap my head around, okay, where do RCOs and where do places like the Crossroads tie into this? You know, where is this in the scheme of silos that's working together with all the other silos? And I want, somebody who says, I want to get a place, but I don't want to lose any money, that doesn't impress me very much, because, everybody will do that. I mean, JFK hopped on, I'm not disparaging, because, we live in a capitalist society, but, JFK got money. They made sure they weren't going to lose money on the ASU. So, I'm all for it. But, we need to flesh out what it is and how it is different from what we already have, and how we're going to have clientele that are actually going to show up. And like Ariana, maybe, you can think about this and how that would impact Delray Beach, if at all. Because I'm not quite clear. Again, I look at RCOs and I look at places that are not officially RCOs, like the Crossroads and some of those other places that Crossroads has 4,000 people go through their place every month or something. I mean, they're crazy crowded with what they do. So I think we need to flesh out a little more, Steve, about what it is we're trying to accomplish and how it differs. It's not duplicating the efforts. Maybe we can beef up something that we already have, like the hub or like the Crossroads. So I don't know if anybody wants to comment on that, or we'll just leave this for the next meeting.
The one thing I want to say though, about that, this is the, for sleeping arrangements and place where people can come to get showered and fresh clothes and fed and be, and be assessed. So I don't know. I don't understand the comparison to Crossroads or the hub. There's no doubt that we would all work in collaboration, but this is similar to a homeless shelter, only with a more capacity and more of a specific purpose as far as finding direction for people. Good direction for people.
That makes a lot more sense, especially for people who need support services. It's a little less of an emergency for somebody who has gone through sober living and now wants to transition, because most of those people, I would think, would have jobs and recovery capital.
Yeah, I want to do recovery support services for them, but I don't think that that's going to be anywhere near as difficult or challenging as getting them into housing, rather than helping them when they're leaving or after they've left. But this other part, I mean, this is life threatening. This is we got to get them off the streets, and we got to get them some hope that there is going to be a solution for them. Otherwise,
all right. Well, yeah. So let's think about that and see how the cost effectiveness would, we have, as John Hewlick likes to say, there's not a lot of money in the pot right now. But this sounds like a really good, idea for that targeted between homeless and somebody who's in treatment or in sober living, a way station almost, a portal.
With a private company running it, who already has a proven track record in minimizing costs and maximizing capacity, with county backing as well as any other kind of backing we can find. I think it's a little bit of a different approach.
Right.
It's just definitely, we have this backing. We have to try something.
Okay. All right, any closing comments on this? And then we'll go to public comment. Everybody? Okay. Hey, thank you. It's been a long meeting and I think a productive one. I do want to hear from anybody who is not on the State Attorney's Addiction Recovery Task Force. And I'll be closing my mind and thinking about that until I get used to saying it. Formerly known as the artist Prince. That's a joke. Formerly known as the Sober Homes Task Force. But anybody, I know we have Katrin O'Leary, Maureen Killian. Anybody want to make a comment out there in the observer public role?
Take a peek.
Is it possible to get the Oxford housing overdose data?
Lori?
Gave you the numbers just earlier in the meeting.
I understand that, but the number that was given was 0 since October,
zero.
and this
It is 0.
so the houses now have to report that.
They report
when
that
we've
to
asked
me,
before-
and they report that to me and I give that information to you all.
Okay. Let me intercede so that this doesn't get into a cross discussion. I think what Lissa is asking is it a mandatory report like it is with FAR?
It's mandatory that they report it to me, yes.
Okay, so in other words, if an Oxford house has an overdose and does not report it to you, they're in danger of losing their charter?
You know, I've never been asked that question, but I will ask that question. I don't know if they're in danger of losing their charter so much as they're going to have to, you know, we'll send people over there to monitor the house or not necessarily monitor, but find out what's going on within the house that would cause them not to let us know about the overdose.
Yeah.
Do you see what I'm saying?
I think, yeah, I do indeed. And I'm just channeling the skeptics out there that are saying, yeah, well, where's the data? Where is it? You know, where can I look at the data? And I know that's not data that you would publish. They just report to you whether they do or not. And I think what Liz is concerned, and some of the activists out there are concerned that they're maybe not reporting it. I don't know what the benefit would be as to not reporting it. I mean, there's no benefit. But I think they just want to know, okay, what's the downside? What, you know, even if it's just laziness. Well, you know, Jane had an overdose, but you know, I don't want to, you know, I'm just not going to report it. I don't know why they would do that, but
I would say that that's very unlikely because when they have an overdose in an Oxford house, it creates a lot of fear. You know what I mean? Like sometimes they don't know what to do. So they immediately call the outreach worker and say, hey, this happened. So, you know, and then also what I have found is that so I have had it happen in an Oxford house in Louisiana where they didn't report it immediately. And it kind of gets into the other Oxford houses, right? Somebody at another house, and then they'll call us and say, "Hey, did they report this overdose to you?" And so then immediately we call the house and we go over there, sit in on their house meeting to find out what happened. But that has not happened in Florida. Any overdose that's happened in Florida for the duration of the time that we've been here has been reported to us.
okay.
We have 10 outreach workers throughout the state, and they're all located in the areas where we have Oxford houses. So as you all know, the recovery community can be very small. And so, you know, people talk to each other, the houses interact with each other, they go to chapter meetings on a monthly basis, they have unity events. So they're always interacting with each other.
Okay.
So it's not likely that there would be an overdose that wasn't reported to an outreach worker and then reported to me.
Okay, well, that makes sense. Thank you. It's more of a community, people watching each other's back kind of data collection if something does go awry, but it would be the outlier, even if it
Yeah,
happened.
I was just caught off guard because we've asked for this almost every meeting for at least a year, and it's either we don't do it or they don't have to do it.
Well,
So when I
Oh,
heard zero,
No, that's not true because I've been giving the overdose numbers for almost a year now. I've been saying it in my report.
But I just want to also make sure, we've talked about this before, that we're on the same page here, that while it's good to know the numbers, just because there was an overdose doesn't mean a place isn't good and run well,
No.
right? Like we all know that with people that abuse substances, that's going to happen. People are going to relapse, and they usually do it in their home, whether it's their parents, their work, or, so.
Yeah.
yeah, for sure.
Okay. Listen, if you have any more concerns, you can reach out to me, but this is, by the way, congratulations on your 79 Oxford houses not having an overdose since October. That's pretty good. And also congratulations to John, to Steve rather, on FAR, because you've had them, but with almost 7,000 beds, you haven't had very many. And that's pretty good. That's a pretty good track record.
And
Yeah,
I want to say something real quick. I'm sorry, Steve. Like, we are really here to help the community, and we have helped a lot of people throughout the entire state of Florida in recovery housing, and we have a lot of people that are leaving Oxford House on good terms, and they're moving forward with their lives, and some of them stay involved and help out with the new members coming into the houses. And, me personally, I would never do anything to try to, like, be dishonest with this. You know what I mean? Like, Oxford House saved my life many, many years ago. And, I just celebrated 15 years sober. And, I just want to do whatever I can to help, the people coming in after me. And so, I just want everybody on this task force to know that I would never, like, just withhold information from people or blatantly lie about anything that has to do with, Oxford House. So I really, I appreciate you all being here, and I think that y'all are doing some great work. And I enjoy being a part of this task force. For the most part, it is a source of contention for me every month because I feel like I'm always like in the hot seat, I guess. But I would never do anything to just blatantly lie to you guys or be dishonest. So
Lori,
I hope that everyone
Lori,
understands that.
Lori, thank you for that. There really is no need. If you knew how hard this task force fought to get Oxford houses into Florida, I think you'd be a lot more relaxed about your role on both this task force and your role in Florida.
Lori, this is tough crowd, but all good.
Yeah, especially you think that Steve Farnsworth would say Oxford House, no, we're the entity here. Never, that never ever happened. And it's to his credit and the credit of the people. That's why we've gotten a lot done on this task force, is because we're all pulling together. And if you think for 1 minute that there's any hostility towards you on this task force, I want to relieve you of that. There is not.
Thank you very
I'd
much.
love to see FAR get $1 million, but that doesn't mean I didn't love to see you get $1 million, because it's like we don't have, we're fighting over scraps here, and we got to get the legislature in the state of Florida to recognize that it's miraculous that there are 79 Oxford houses here, where a few years ago there were none. And there's 661 beds, where a few years ago there were none. So pat yourself on the back. Don't worry. Don't give it another thought. People do want to see data, and sometimes the data is not available in terms of a report, and it doesn't need to be. And so just it's all cool, right, Steve?
Absolutely. The peer support nature of the Oxford houses is powerful. But that would explain, the numbers, I suppose. But I was, as I was listening, I was kind of throwing a calculator around as to, how many beds they have compared to how many beds I have, and with just under 7,000 beds, or excuse me, that's not the number I wanted. Just under 40, or right around 4,660 beds if you don't include the level 4s. And I got 54 overdoses in a year. So I'm not really completely surprised that she has 0 overdoses. If you consider the peer supportive nature and the number of beds that she's dealing with, and the oversight that they provide with people like Elizabeth and Michael and the other people, Chandra, the rest of them, all of them.
Yep. Thanks, Steve. I see we have 2 more. Shelby Meters, you've got your hand up.
Hey, I just wanted to say hello, Al. Thanks for inviting me. I'm happy to be here. My name is Shelby Metters with the Department of Children and Families. I run the overdose prevention program and naloxone distribution program. So I heard a lot of talk on naloxone today. I think that's great. I wanted to point out a free resource for people looking for free naloxone. You can look it up by your county if you just go to isavefl.com. You can click your county and find all the providers that distribute free naloxone. No questions asked if you're at risk of witnessing or experiencing an overdose. So I just wanted to share that information. I also put that in the chat with my email if anyone has any questions on the department's naloxone program.
That's awesome.
I see a lot of people in here that distribute through us. So the
Can
healthcare
you-
district just got their shipment.
Shelby, can you put your email address on the chat so people can contact you to get that information rather than spend time, but you put it on the chat. And also Marianne has your email address. So if anybody doesn't get it on the chat, just contact Marianne, and so they can contact you directly to see where the resources are available. How's that?
You got it. Thanks so much.
Okay, Katrin, I see you have your hand
Al,
up.
yeah, I actually have 3 questions. One of them first, I'm not going to go and dwell on the overdose on Oxford, but what I like to know is, we always say, each and every entity has its place. And what I really like to know is if they are keeping track on the length of stay of folks who are coming into the Oxford houses, what the turnaround is, especially, the folks who are coming out of the ASU units, who are, still detoxing, versus the, should be more of a 3/4 home in my eyes. I'm not a professional. I just feel like, it's more of a 3/4 stays for somebody who's actually went to a more supervised sober home and then step down to the Oxford house. Number one, I'd love to see if there's some kind of.
Katrin, I'm gonna just interject here because we only have a minute. I want to get all 3 questions. And I'm gonna run interference for Lori. And correct me if I'm wrong, Lori, but I don't think Oxford House is the place where many people go from a stabilization unit like ASU. I don't
Right
know
now,
if you have
they're
anybody
going anywhere where there's an open bed, Al. I'm sorry for
Katrin,
correcting you.
let me ask Lori, do you generally get people from that are in crisis mode or
We
are in
don't
active addiction?
necessarily track where they come from. We do the interview. Now, each individual house probably does. The only thing that we track with that is we do an annual survey once a year that gives us kind of an overall statistic of the year, or it's called oh my God, I've lost the name of it, but it's like an annual profile of Oxford houses in Florida. And I have that information that I can send out to you, Al. I'll get it from the office and they can probably, it'll send it out to you. But
that's wonderful.
Generally, the interview process, we don't, so the houses interview people and they decide who they want to take by 80% of the vote, right? So if they decide to take someone that is coming from ASU, then that's their decision to make. Does that make sense?
Yeah, it does. And you know what?
So
Maybe
there's
in the March meeting, if you can put those year-end stats together and just give us a 5 or 10 minute lowdown on what you do know or what statistics you do keep. And that I think that would go a long way in everybody understanding what's happening in Florida with the Oxford House. I realize it's individually run, it's democratic, it's different from FAR. Which lends itself to the necessity that you're going to have people who are farther along in their recovery that live in an Oxford house and survive and are able to be there. And my understanding is it is longer term than it would be in one of the levels of the certified recovery residences under FAR. So let's, okay, Katrin, you had another question?
Yeah, I mean, I know because, our moms grassroots, are being reached out to when the folks don't have any monies, and we actually, they're writing the checks to it. So that's the reason why I'm familiar with the numbers. I wholeheartedly support what Steve said, because that's the missing link, especially since you don't have, 100% warm offs from the ASU unit. It would be a phenomenal place for them to stay as well, and would save a lot of lives. And my next thing was about the ASU unit, if they would be possibly able to go and start handing out Narcan right off of the unit, because especially when we don't have the warm handoff, especially since that population is, in, very high risk of overdosing after leaving, not into, a safe community. So that's my spiel for today.
Thank you, Katrin. Hey, John, I know that Belma had to leave. Would you communicate that to her, the last ask of that Katrin had, that is it possible, if it's free and doesn't impact the budget of the Palm Beach County Healthcare District, to be a
Because
source
they
of
are
giving out the
actually giving it
Narcan?
out at the pharmacy, it would be phenomenal if they can do it right out of the ASU unit as well.
Yeah. So
I'll pass the comment along. I imagine JFK would, obviously they'd have to agree to it. I would assume.
okay, all right. So we can keep tabs on that. And any other comments from the public? Go ahead, Katrin.
That's it. Thank you.
That's it. Okay, you didn't put your hand out. All right, Maureen, we're over time. Give us what you got.
Quick request for the morbidity and mortality data to report it now that we got the fabulous health department do what they're doing. Can we get a total overdoses of deaths and survivals so that we can see if we had 20 in March who died and 30 who overdosed, we have a total of 50 real live numbers that way. Thank you.
We can extract that at least for 50% of the county by looking at the opioid transports. Now it's going to lose the walk-ins. If somebody drops somebody off in a heap at the at a hospital. But
no, I mean, like with the ME data too. Like, let's do ME who died, and let's do those that are making it to the hospital now that we can.
Well, we've got the ME data. We know for a fact.
Just want to add it.
In 2020, there was 604 opioid overdose deaths. We also know from Palm Beach Fire Rescue exactly how many, and that doesn't, unfortunately, we don't have data from all the fire rescue, and that is something that Whitney, we can work with, because our task force has not been able to get that data from any other fire rescue organization than Palm Beach County Fire Rescue. It's approximately
I've actually
50%.
gotten some, I haven't played around with it, but I've gotten some access to Biospatial, which includes all the EMS reporting. I don't know how specific it is, but it does do some query options. So I might be able to help with that.
Well, here's a stat that you can glean. If you have all the overdose transports from the county, we know we have a fixed number of 604, say for 2020, 604 overdose deaths. It's mathematics, give or take, obviously, because we don't capture everybody, but within a few percentage points, we can know what the morbidity rate is as opposed to the death rate by the number of transports, and you subtract 604 deaths.
I would argue that you can't, because a lot of them will use Narcan and never even call EMS. Their friends give them Narcan and then they're fine. So it's like, it's always,
which is why it's not going to be, there's no way of knowing the number.
Right.
But what there is a way of knowing is the number of transports, so we can at least see a percentage of that. I'm just saying, Maureen, I hear you. That's about as best as we can do right now.
Yeah, I just want that 16 per day. Is that the deaths from the ME report? 16 per day?
16.7 in the state of Florida.
And if we added how many overdoses, what is our total? What's happening in the state of Florida? 30 per day?
No.
That's where I want to go.
Oh, the overdoses would be far more than 30.
And deaths, overdose and deaths, 30 a day, 50 a day, 100 a day, instead of just reporting 16.
I don't think we can get those numbers.
Okay.
Check Department of Health. I think they might have the totals for for non-fatal overdoses, though I'm not sure if they specify opioid.
Isn't that me?
Oh yeah, it's you. No, I don't know why it's I
was
no,
like, wait a minute.
besides you.
Okay.
For the state, yeah.
No, yeah,
Um,
but it only counts those who show up in the hospital. Yeah.
Well, that's awesome. Let's talk further about that, because I think that'd be an interesting number. And I know we don't capture, we're certainly not going to capture the ones we don't know about. But we have the data that we have, not the data that we'd like, which is complete. Okay, any comments from the task force before we leave? We're about 8 minutes over. I'm sorry about that. I usually try to get us out of here early, but a lot of good stuff. Thank you all for participating, and we'll see you in March.
Thank you. Thanks for a great meeting.
Take
yeah,
care.
thank you so much.
Thank you, Al.
Thank you, Al. It's good to see you. And everyone else.